welcome. Welcome this morning. We're just going to give it a couple minutes while the participants connect. Thank you for joining us this day. Just waiting for a couple more connections and we'll get started. All right, welcome. We are so excited to have you join us today for our workshop, The Opioid Crisis in Children, How to Manage Their Pain and Protect Them from Harm. This morning, I am delighted to have us joined by Dr. Samina Ali. She's a pediatric emergency medicine physician at Stollery Children's Hospital and a professor of pediatrics and emergency medicine at the University of Alberta. She completed medical school and emergency medicine fellowship at McGill University and pediatric residency at Memorial University. She recently completed a Mayday Pain and Society Fellowship in Science Communication. Dr. Ali is a national award-winning researcher, mentor, and educator. Her research program concerns better treatment for children in the emergency department with a focus on responsible prescribing of opioid analgesia and management of medical procedural-related pain. She holds national funding for studies informing best care for children with acute illness and injury. Welcome, Samina. We are also joined by Dr. Naveen Punai. He completed his Doctor of Medicine at the University of Toronto and his pediatric residency and emergency medicine fellowship at Western University. He holds a Master's in Science and Health Research Methodology from McMaster University. Dr. Punai joined the Department of Pediatrics and the Division of Pediatric Emergency Medicine in 2009 and is cross-appointed in the Department of Medicine and Epidemiology and Biostatistics. He's a scientist at the Child Health Research Institute and serves as research director of the Division of Pediatric Emergency Medicine. He's a member of Western University's Health Science Research Ethics Board and the CIHR College of Reviewers. On a national level, he's decision editor for the Canadian Journal of Emergency Medicine and the Pediatrics Section Lead for Best Evidence in Emergency Medicine and Pain Assessment, the BEAM Toolkit Lead for the Children's Healthcare Canada, and a member of the Pediatric Emergency Research Canada PERC Executive Committee. His research interests include procedural sedation and management of acute pain in children, and his recognitions include the John Jyer Research Excellence Award from the Division of Emergency Medicine in 2007, the Young Investigator Award from the American College of Emergency Physicians in 2018, and the Terry Clausen Young Investigator Award from the Pediatric Emergency Research Canada. Welcome, Naveen. And we are also super delighted to have Dr. Amy Drendel join us today from the Medical College of Wisconsin, where she is professor of pediatric emergency medicine and medical director there as well. She is a site PI for the Pediatric Emergency Care Applied Research Network, PCARN, IMPROVE study, looking at pain management and post-discharge pain outcomes in children, where she is a master of pain assessment and a huge advocate for pain research. We are super excited to have Dr. Drendel join us today. And I'm your moderator for today, Corey Chumpitazi. I'm here at Baylor College of Medicine, Texas Children's Hospital, where I have an interest in quality pain and sedation management, quality improvement and education. I'm a site PI for our PCARN studies, as well as the Emergency Medicine for Children Innovation and Improvement Center, Knowledge Management and Research domain leads. So we just have a stellar lineup for you, and our agenda for today, we're going to start with try to keep things interactive. So we're going to utilize the chat. Please mute yourself when you're not speaking, but we will have an opportunity to engage with you all and really want to have this interactive section. So Naveen, will you show us the agenda? So this morning, over the next 45 minutes, we're going to start in with pain assessment. Is pain assessment bad for pain treatment with Dr. Amy Drendel? Then we're going to move on to opioids and our children. First, do no harm. There'll be time at the end for interactive questioning after each of these sessions. We will have a break from 10:45 to 11 a.m. Please use that break. Get water, get food, turn your cameras off, get a stretch break. But if you do want to stay on, our speakers will be staying on. If you have any directive questions or interactive questions during that time, we'd love to have you join us. From 11 to 11:45, these are all Central Time. We're going to talk about innovative ways to manage acute pain with Dr. Naveen Punai. And then we're going to wrap up in that last segment, integrated pain management and quality improvement.
So she didn't get her leadership training.
Sejana, it just, oh yeah, perfect. And so our objectives for today, you can see in the program, and then we've also got them listed for you here on the next slide. So we're going to discuss age and developmentally sensitive pain assessment modalities and their role in responsible prescribing. We're going to describe the competing and complementary dynamics involved in pain management for children during the opioid crisis. We're going to discuss the current and potential future choices and roles of our acute pain tools in analgesia toolbox. And so really getting you engaged and trying to think about what tools are you using. And then identify quality improvement initiatives and policies that can be adapted to aid in the use of improved pain management. We are going to kick it off with a video that really helps us inform why we're here today, and we are really excited. Can you turn the audio on, Naveen? Naveen, the audio is not coming across. We can pause and restart.
How about now?
Still can't hear it.
It's on maximum.
Okay, let me stop 1 second. Let me try to, I will just reshare. Oh, you're right, that's not sharing either here.
Hi everyone, this is one of the MSAs. You may need to share your computer sound in order to get the sound to work. So under options, there should be an option to share your computer sound. When you share your screen, yeah.
All right, we'll just take a quick look at that. But basically what we want to share with you is just an interactive video about why we're here today. We are really interested in the pain sciences rooted in rigorous research. And we know that there's a 17-year gap in that practice to knowledge to practice transition. And so we really want to try to cut down on that and improve outcomes. We know that pain is the leading emergency medicine complaint for over 80% of children, and that kids' pain is managed a lot less well than adult pain. So let's try this one more time, and if not, we'll put the video link in the chat just because it's a great video produced by Skip Canada. Still no sound, Naveen? I don't know if there's...
Still no sound, no.
Okay, we'll just watch the video quick. But it said, you know, with that 17-year gap, it's a whole generation of children that don't have pain management, and that 1 out of 3 children present with pain. And we do painful procedures and a lot of other things to these children. And so how can we think about how we manage pain, and how do we train people in pain management? We know that veterinarians get 5 times the amount of time than physicians in learning pain management. And so how do we do this and treat pain well? We know that kids who don't have great pain treatment have decreased harms that last lifelong. They delay seeking care, they don't get immunizations and other procedures. And so that's what we're here to do today. So with that, we can pause this. Naveen will put the link in the chat, and then we'll move on to our first speaker, which is Dr. Amy Drendel. So we are excited to have Dr. Drendel join us today. And we are once again going to talk about pain assessment. So we'll share these slides in just a second.
There we go. Thank you very much. So thank you, Corey, for that introduction. Appreciate it. I'm super excited to talk to you guys more about pain assessment and the role of pain assessment in pain treatment. On the next slide, you're going to see that pain assessment really has gotten a bad rap lately. It's hard to understand why. Pain assessment seems to be like a good thing. Maybe if we can go to the next slide, but somehow it's become controversial. Why has pain assessment become controversial? Well, parents are afraid that the pain score will result in a prescription of an addictive medicine. Healthcare providers are thinking that kids are exaggerating their pain. Healthcare providers, they're aware of the opioid crisis and they're altering their pain management strategies. And then there's some administrators that know that lower pain scores and better pain treatment do result in increased satisfaction scores. And they're trying to figure out ways to try to incentivize that. Kids need a way to express their pain and communicate it in persistent and its severity and it's persistent in a reliable way. And that just brings us to this discussion about pediatric pain assessment today. So next slide will show us the objectives. So the science of pediatric pain assessment has come a long way. And I'm hoping to give you a better and deeper understanding of what the child's perspective is on pain assessment and focus on some practical aspects that affect your everyday care of kids. We're going to talk about pain assessment and the role in both patient care and management, and then do a little bit of a historical perspective about where we have been and where we plan to go in the future. Next slide. So pediatric pain assessment science has really been evolving. This visual here shows you how the expansive published literature has just exploded over the last decade, particularly in the last few years. In 2020, there were over 800 publications about pediatric pain assessment, which is incredible. Much of this work has been done around development and refinement of pain measures that are specific for kids. And the focus has really been on getting the right measures for kids with particular needs. So generally that means a pain assessment tool that is right for everyone, but it's very much particular to their developmental stage. So kids here you can see are uniquely unique in that their pediatric pain assessment isn't just going to be as simple as what you might get at the doctor's office as the numeric rating scale of 0 to 10. How painful is this lecture going to be about pain assessment, right? So most kids down to 8 years of age, we'll go back one slide, down to 8 years of age can actually do the numeric rating scale and do that pretty reliably. But even in the most stressful situations, many of us revert back a couple of years and start acting more and less like the developmentally appropriate age that you are. So there's a lot of 8-year-olds that won't be able to do a numeric rating scale in a stressful, painful situation. So these FACES pain scales were developed for kids 4 to 8 years of age. And it gives a visual cue to really help kids to better understand what that pain assessment means. So the FACES pain scale revised is probably one of the most reliable scales that is used in research. You might actually recognize it from your clinical space as well. Overall, they found that there's about 7 of these FACES type scales that are reliable for use, and the FACES pain scale is one of the most reliable ones. Next slide is going to show you a unique one that's called the Oucher scale. If you recall, that FACES pain scale was kind of Martian-like. Can't really tell if it's a boy or a girl. Can't even tell the race ethnicity of that. The Oucher scale actually kind of doubles down and says, you know what, we need to be more specific about what the gender of the patient is, the race ethnicity of the patient, and try to match it up with the patient that you're actually trying to assess. They also, instead of being horizontal, is more of a vertical approach. And so this is actually also quite a reliable assessment tool that can be used with those kids 4 to 8 years of age. One downfall of this scale is there's about 8 different versions of it, depending on if you're a Black girl or a Hispanic boy. So that's a little hard to manage practically in the clinical arena. So probably not as commonly used in your practice. Next slide shows the observational scales, and these are particularly focused on the kids who cannot report their pain scores. Typically, this is kids under 4 years of age, but again, sometimes even those 4-year-olds will have difficulty. There have been about 20 observational pain scales that have been recommended, and the FLAC is probably most commonly one used. Now, I would say most providers don't know how to use a FLAC scale and don't use one on a regular basis. And this is something that the nurses do a really top-notch job of doing assessments for. It's a 10-point scale and essentially assesses the faces, legs, activity, cry, and consolability, giving 2 points for behaviors that are associated with increasing levels of pain. So if you get a quivering chin, you're kicking and screaming, you're arching your back, crying, can't be consoled, well, you're a 10 out of 10 based on this observational scale. So the first tip I'm going to offer to you is to know what pain scale your institution actually uses and to learn about those scales, because every scale has its pros and cons. And knowing the shortfalls of the scale will actually help you to do a better job in pain assessment for those kids. The next slide shows one that's very commonly used in emergency departments across the country. It's called the Wong-Baker Faces Pain Rating Scale. And I think it's commonly used because it's cute, right? Like it's something that's really, kids are drawn to and kids really like to use it. You need to keep in mind for this scale that, as you can see, it's a 0 to 10 scale, but only even numbers are used, as is true for most of the faces pain scales. But you can see the low anchor there is a smiling face. So it's possible that you're actually going to get a little bit higher scores for mild pain than you would on other scales. And then you can also see there's a crying face on the high anchor, which you actually might see lower pain scores for more severe pains because kids are very, very specific about not picking that scale, that 10, if they're not actually crying. So those kind of aspects about the particular scales, I think can really help make a difference in a more reliable assessment of the pediatric patients. So this is going to be our first question. Let's see if we're successful in pulling this off. So I'm going to have you choose the right pain assessment scale based on the developmental skills of the child that will result in the most reliable determination of pain severity. So which of the following is not best practice? The faces pain scale revised was shown to a 10-year-old presenting with a burn to the right hand, so he could self-report his pain. The numeric rating scale was used to verbally assess the pain severity a 15-year-old experienced after an inversion ankle of her ankle. The nurse observed the 6-week-old baby and used the FLAC scale to assign a pain severity. Or the mother observed her 6-year-old child using the visual analog scale to estimate his ear pain for him.
And we're starting to see some answers trickling in. Go ahead and make your final answer. They're anonymous, so go ahead and vote. Okay, can we show those responses?
Nice, good job. So the right or wrong answer is the mother observing the 6-year-old using the visual analog scale. So the last answer, which 53% of you got right, is the right answer. So some of you had chosen for the 10-year-old that maybe the faces pain scale wasn't a good choice, which again, depending on the situation, it might be all right to use the faces pain scale because especially with severe pain, sometimes they don't do as well with the numeric rating scale. Other hint to just in practical clinical sense is if you find that a child really is using 10 or 0, no matter what, that usually means that they're in a position where they're not actually utilizing the scale as you would expect. So if every time you talk to them, they're 10, 10, 10, 10, it might mean that they're actually not utilizing the full scale. So that's another reason to consider using the FACES pain scale instead of the numeric rating scale. So great job with that. So yeah, so what is the role of measurement in treatment? So just as a child who's getting antihypertensive medicine should have regular blood pressure assessments, a child who's receiving an analgesic should have regular pain measurements recorded, right? Like that's kind of, I love that analogy. It just makes sense, right? So one critique that I often hear about pain scales is, okay, now I've got a number, but what am I gonna do with this number? What does 10 mean? What does 6 mean? What does that really matter at all? So I'll show you here the other scale that we're showing here is the stoplight pain scale that I helped to develop. And we're hoping to have a more simplified scale that use both faces and colors to help guide children to make an assessment. And our goal really with this pain assessment scale was to try to tie the assessment with what intervention would be recommended. So if you're okay and feeling fine, there's nothing to do. But if you're red and you hurt, then something needs to be done. Or if you're yellow and not sure, then that pain needs to be assessed again. So this is at least our attempt of trying to connect the dots between that assessment and pain treatment as well. Another approach that's been evaluated in research is to evaluate what is a clinically relevant change in pain. And the good Dr. Daniel Z has shown us that a minimum clinically significant difference is 1 face or 2 points. And whoops, sorry about that. And so a minimum clinically significant difference is a little less pain. And the ideal clinically significant difference is 3 points, meaning it's a much less pain. So if you're starting to see movement in that pain scale by at least 1 face or 2 points and up to 3 points, then you can feel a little bit better that you're making a clinically relevant difference in that child's pain assessment. So what do you use pain assessment for? I think there's actually 2 big buckets that you use pain assessment for. One's a diagnostic indicator. It really guides your diagnostic evaluation, optimize your diagnostic accuracy. And then the other is really symptom assessment. So it gives you an awareness that a child is experiencing pain, also helps guide your treatment decisions, and really, most importantly, reassessment after an intervention, because indeed pain assessment is a very subjective experience, and truly the same pain might be a very different number for a patient. But on reassessment after an intervention, if you're gonna have a more reliable response to that pain assessment by monitoring its change over time. So my tip number 2 is that all pain scales measure an individual's experience. So comparing that pain score to the prior measure is the most reliable way to use a pain scale for that individual. So here's our next question up for you. Who is the best person to report on pain severity? Is that the patient is the most reliable report of the pain? The parent knows the child best and will give the best pain assessment of severity. The healthcare provider has a better understanding of clinical care of the patient, is the best person to evaluate pain severity. Or the severity reported by the patient and the parent and the healthcare provider should be averaged for the best report.
There's a battle going on in there. Keep your answers coming. Go ahead and vote, please.
Yes, the patient is the most reliable report of pain severity. Excellent, good job. So indeed, it should be, the self-report is the most reliable report. If you can get the self-report, then that's the way you should go. Both healthcare providers and parents universally underestimate pain. And actually, as healthcare providers, you underestimate pain even more severely than parents do. So you should listen to kids. And if you can't hear the voice of the child, then at least listen to the parents, because they know better than you what the child's experience is. And truly, you don't want to punish a child who has coping mechanisms for pain just because they're not showing overt signs of pain. And this has come up in the assessment of what the utility of vital signs are in pain. And I've definitely heard from people that, well, I don't know, if the pain score is 10 out of 10 and the heart rate's not up, I don't know if I can accept that as a reliable pain assessment. And in fact, except for infants, a change in heart rate has not been strongly associated with increasing pain severity. So definitely listen to the kids and what they're saying, and reassess over time as you incrementally increase your interventions to try and address that pain. So tip number 3 is always ask the child for their pain assessment. And that's going to be the most reliable report. So many questions. So pain assessment is associated with more pain treatment, including increased administration of opioids. Is this true, false, or you don't know because you think it's a trick question?
You're so sneaky, Amy. They don't know if they can trust you anymore.
No.
Final answers.
Okay, so I got you on this one. In fact, pain assessment is associated with more pain treatment and is associated with increased administration of opioids. Let's do one more question, then we'll dig into this one a little bit more. Let's see, we gotta close out that poll.
Yep. Yeah, this is it. Right?
Yeah, let's close out this poll. And then we've got a new one. There you go. So one other question is, studies suggest if pain is not assessed, the analgesic administration pattern is like the treatment of children with moderate pain. Is this a true, or is this a false? Or again, I don't know, because you think it's a trick question.
Final answers are trickling in. Make those votes.
And well, so 80% of you thought it was true. So in fact, kids who are don't have their pain assessed are treated like they have mild pain. So let's look at the next slide. So I was a part of a study that looked at the NAHAMSIS database and looked at emergency department visits for kids. And we looked at pain assessment and its relationship to analgesic use and opioid use. And this table really nicely represents the findings of the study. On the left column is the analgesic use, and the right column is the opioid use. And you can see running up and down from no pain score all the way up to severe pain score. Your odds of receiving an analgesic between going from mild to severe pain increases from 1.5 to up to 4. And your opioid prescription rate increases from 2 up to 22. So in fact, as pain becomes more severe, we do actually respond pretty reliably to that with analgesics and with the most severe pain to opioids. The interesting thing about the study was that there were about 20% of patients that didn't have any pain assessed. And so that no pain score group in that top column shows that actually the analgesic prescription pattern and opioid prescription pattern actually looks very much like patients who had mild pain. And so that suggests that you and I, if we don't do a pain assessment, just kind of assume that the pain is probably of the mild severity. And it's probably not a reliable approach to pain management in general. So this, again, just kind of pushes the idea that pain assessment can drive practice and should kind of inform your approach. And it doesn't mean that you always give an opioid. It just means that you need to incrementally increase your interventions based on the response that you would assess with your pain scale. Next slide. So tip number 4 is simply assessing pain should optimize the important pain outcomes. So the unique aspects of pediatric pain need to be considered as we talk about pain assessment, because historically pediatric pain was not well recognized. We're going to talk a little bit more about that during this talk. Children are much less likely to report pain. And I think also that differentiating between anxiety and distress and pain is also very difficult to tease out. And so you don't really know what you need to address. In general, children do not receive pain medications at the same rates that adults do. There was a recent study that looked at fracture prescription rates. For kids, it's down into the low single digits, and still adult practice is in the mid 40s. So I'm not sure what the right approach is to prescribing for fractures, but I don't know any good physiologic reason why a child's pain should be different than an adult's pain with a fracture injury. So I think there's work to be done going forward, right? So just to give you a little historical perspective, I'll walk down memory lane as you might with regards to pain assessment. Just in my lifetime, I've seen the pain assessment approach swing wildly. So back in the 90s, pain really was invisible. Pain relief was really nobody's job, and we kind of did what we did, right? In 2001, the Joint Commission came down with pain as the 5th vital sign. And that kind of changed practices in hospitals across the country. But by 2004, that phrase actually had quickly disappeared, and it was in response to the opioid crisis. By 2009, the pain assessment requirement was removed by the Joint Commission. And in 2016, the AMA actually dropped pain as a vital sign. So by 2017, pain assessment was considered a multifactorial issue. So we went from basically don't assess pain to you need to always assess pain to back to don't assess pain at all. And likely assessment, I think, is good. It's important, right? It's really what was tied to those assessments that led to problems down the line. And I think fixing that problem is probably more important than just throwing out pain assessments completely. Next slide. So there is an argument against pain assessment, and I'd like to at least consider some of the concerns around pain assessment, right? So if there's an idea that reducing the assessment of pain down to a single number and then tying that assessment to direct action can lead to problems. And these are these treatment algorithms that were used to facilitate an analgesic decision-making. It's helpful to have algorithms, but I think really pain is kind of a personalized approach, especially knowing the subjectivity of pain assessment in general. Again, too, pain assessment, it has been tied to inappropriate prescription of opioids, whether it was to improve satisfaction surveys or to avoid financial and professional penalties. Neither of these are a good idea. I think an incremental approach to pain treatment, as we're going to talk about later, is key, and pain assessment is just the first step in that. And then there were a lot of unused opioids that result in a source for abuse and misuse. And that is unrelated to pain assessment, but a problem all the same, right? So pain assessment for kids, what you really need to do is pick the right pain scale, obtain that pain assessment for the child, thoughtfully treat the pain using your best judgment, and then reassess that pain to evaluate the response to the interventions for that diagnostic evaluation. So overall, my tips for you are to know your pain scales, compare the pain score for that child to their last report, ask the child for the pain assessment. If you can't get it from the child, then a parent is an okay report. It's better than your report of the child's pain. And then pain assessment does optimize outcomes for kids. So I really appreciate you guys taking the time to listen more about pain assessment. I do have a couple more minutes where I could take some questions too. So Corey, should we open it up for more questions then?
Yeah, that would be great. If you guys feel comfortable typing them in the chat, keep them coming, or go ahead and raise your hand and we can have you unmute yourself and ask Amy. We're so delighted to have such an expert in pain assessment and management with us today. So I'm really excited to pick her brain. And I know you are too. Any of the controversial, I think she did a great job of integrating some of that, the questions around pain management. And so we are monitoring the chat, and I'll give you all a minute to think or type those questions on in. Go ahead, Dr. Berger.
Hey, Amy. So I was going to kick off our discussion by talking about what ages you think it's okay for self-reporting to occur. And then in those age groups, is there a preferred scale that you like to use? Sure, yeah. So observational scales are probably best used under 4 years of age. There's some 3-4-year-olds who will do that FACES pain scale, but under that, you really need to do the observational scales. So then when you're starting to do pain assessment to have the self-report, so it's about 4 years of age and older, using one of the varieties of the FACES pain scales is best from 4 years of age up to 8 years of age. I think the research world uses a lot of the FACES pain scale revised. That's that Martian looking face that you guys see out there. That essentially gives you a 10-point scale that only gives you even numbers, that gives you a pretty good assessment. And for kids to try to abstractly put into a number their pain experience, that face actually gives them some grounding on and the capacity to be able to do that. Over 8 years of age, they should be able to use the numeric rating scale, and that's basically between 0 and 10. What is your pain right now? They should be able to use all parts of that scale, and that'll give you actually 10 points to work with, and a little bit more detailed then, right? As opposed to just the 6 points that you get on the FACES scale. You will find somewhere in that 6 to 8 to 10 years of age that sometimes you'll get into trouble. So I'll say boys have more problems with these scales than girls do. And then with severe pain, they can also have problem with scales. So the numeric rating scale, you should be able to use that in an 8-year-old, but if they're in a lot of pain, or they're one of those boys who's having difficulties with it, then you want to go back to using that FACES pain scale. And again, if you notice that they're only using one end of the scale, that typically is a sign to you that maybe it's worth trying to use the FACES pain scale to see if that makes a difference. Now, is there a FACES scale that I prefer over others? I think the Wong-Baker is probably the other one I see most commonly out there. And I don't think it's bad. It's just as a little bit limiting in that the crying scale, the crying on the one end and the happiness on the other end really limits you to basically a 4-point scale, right? Because you've eliminated both ends for many kids.
So that's probably the biggest downfall to that scale, I would say. And then a lot of the other FACES scales end up requiring you to have things and not just like one card that you could show to a child, but many cards or many things or many pieces of things. And those I think are really hard in the ED setting to be able to use effectively and to keep sanitized and all the other things that you need to efficiently be able to assess a child in the ED setting.
Yeah, great point about the FACES, Wong Baker FACES, and Dr. Ali in the chat as well said, you know, for some cultures, the crying faces, like you said, take off that anchor in addition to just, well, I'm not crying this second, so then I'm not a 10, is a really great point. And I want to, a follow up to that question was raised by Danny Braithwaite. I want to bring attention to our medical student ambassadors. They've gone through a rigorous selection process within the SAEM meeting for folks who are interested in emergency medicine careers. So we have Joelle Brown and Danny Braithwaite are on the chat with us today. And Danny brought up a really nice follow up to that question too, in are there patients that you think like when they're might be lying, or are there specific situations in which it's not advised to ask patients to describe their pain?
Yeah, so that's tough, right? So if I think anyone could lie, right? Like, sure, you could probably misrepresent the pain that you're having. I think some people worry that there's exaggeration or misrepresentation when they get a report from a child that doesn't seem to represent what they're actually seeing in that patient. And I think some of that can be coping mechanisms. I often hear, well, she's texting on the phone, so how much pain could she be in, right? And I definitely see kids using different coping mechanisms, trying to help alleviate some of that pain that they're experiencing. So I hate to think that because a child is using coping mechanisms that they get somehow punished for in their pain assessment. So I think you have to take them for what their word is. I think you can kind of incorporate though in your clinical acumen about the case. So if you have a hangnail and the child says that is 10 out of 10 pain, you have to recognize that that is their pain experience. And then you use your clinical assessment to say, for a hangnail, I am not going to give a dose of fentanyl. I am going to give something else that should relieve that pain experience. And then whatever intervention that you decide to administer, you do that and then reassess the pain. And it could be for that individual that 10 is what it is, and that your intervention then might take it down to 2, and then that's what it was, right? So I would prefer to use the pain scale to help you guide your treatment and guide your management than to be to kind of judge the severity of the pain in face of the clinical condition. Does that make sense?
Yeah, I think
thank
that's
you so much.
Yeah, and that goes kind of hand in hand with Dr. Ali. Did you have something to jump in the related vein with your question?
No, I think Dr. Drendel addressed it. It was just that same idea as when someone says it's 10 on 10, does that mean it automatically needs IV opioids? And I think it can be a 10 on 10. As I'm reflecting on what you're saying, you know, if you have a 5-year-old who's had a very sweet life, their 10 on 10 is their 10 on 10, not mine where I've had injuries or operations, right? So I think that's what we have to remember. It's a relative scale for them, but you covered that perfectly. Thank you.
And in sticking with that same vein, Phil had a question about the teenager too with sickle cell pain. I do sickle cell pain research, as many of you do. And when they're comfortable on their iPhone, how do we advocate for those patients and, you know, work with the nursing team or our colleagues when they say, oh, but they're on their cell phone, we're good.
Yeah, I think especially the acute on chronic pain is probably one of the hardest to manage. And I think our adult colleagues probably deal a lot more with that than we do, just in general in pediatric care. But it's interesting, so that stoplight pain scale where we use the red, yellow, green, we went to kind of using that approach with our sickle cell patients. Because essentially what I need to know is not necessarily for the sickle cell patients, we know that they've got pain and we know that we've got interventions to make them feel better. And the goal is to get you the pain under control well enough to be able to send you home. So it's kind of a dichotomous outcome. Like, do you feel good enough to go home or not? Because the number actually doesn't help me to be more aware of the pain severity. It just helps me to know that we need to stop our ED interventions and move on. So we've moved a little bit to using kind of I'm green, good to go, or I'm red and I still need to be on the protocol approach that we kind of have an agreement on how we're going to manage that pain. So I think that's an extremely challenging group. And I think there is risk for judgment on those cases in particular, and very complex, and knowing what their goals are and what the goal of the visit is and what the planned approach can make a big difference in kind of guiding that treatment.
Yeah, I just love that. I'm very simplistic as an ER doctor that, yes, I need to do something. No, I'm, got to think about it, got to reassess, or nope, we're good. And so I think that's a fantastic way. And I think really the bottom line is whatever system your institution or health system is using is just to use them and try. And then we're going to talk at the end if there's ways to quality improvement, switching your pain scales, that there's that too. But I think just assessing is that first step, and then reassessing. And we're really going to get into, it's not a yes opioids, no. It's what other is our armamentarium, and do we have tools in our toolbox, and can we go through a stepwise approach to thinking about that? And that's what we're going to do through the rest of this session. So thank you for that. Let me see if I have any other hands or folks saying thanks. Naveen agrees that just acknowledging the pain is that first step, and then figuring out, working out with the patient and their family, depending on that age, what does that mean to you, and how can we meet your goals for your pain management? I'll open that up to our panel too. Any other questions on that? Or follow up? Naveen, did you want to expand?
Yeah, I think it's a really good point. And I think from regardless of where you work, you're always going to see a patient who you think subjectively is comfortable, but they're saying that they have 12 out of 10 pain. Yeah, it happens. But I think the moment we back off from our approach is a slippery slope to when we decide that, oh no, okay, 10 out of 10 pain isn't important. But for patients who, it actually is a very important metric. And I honestly think that some patients really just want that acknowledged. And a lot of kids are really good at hiding their pain as well. So it's something to consider.
Yeah, I think so. Sometimes we think that they're trying to seek pain to stay with us, or to, do those things. Not that you can't make that universal assumption. A lot of the times the ER is the last place they want to go, especially in our transition patients and transitioning to the adult ERs. We get feedback from our chronic pain patients. That is the absolute last place they want to be as well. And so that acute on chronic especially is quite challenging. And I think that too brings up, children with special healthcare needs, and being sensitive to their pain management and trying to get to the bottom of what's causing their pain and what modalities work really well. But that can be challenging as well. I don't know if anybody had specific questions around that population as well.
Yeah, that's a great point. I think the special healthcare need population is unique in their developmental skills. And so that it might be that you need to use an observational scale for a much longer and wider age group than would normally be expected. And as well, those parents are much more reliable and really kind of can give you the insights into into the pain experience of that patient, because they're much more in tuned into what is normal or not normal for that patient. There are some particular scales that are specific to that patient population that are worth looking into, especially if you see a larger population of those of that type in your emergency department. But again, observational scale and relying on the family for kids with special healthcare needs is very important.
Amy, I had a question going back to your former study where you're talking about if there was no documentation of a pain score. What kind of pain was it assessing? Like, what were the patients? Was it only like injured patients, sickle cell patients? Because I feel like, especially like fracture patients where there's an obvious deformity, even without a scale, you can, guess their amount of pain versus obviously a sickle cell patient or somebody else, it's much more difficult.
Yeah. That paper included conditions that were considered to be painful, from fractures to ear infections. We pulled all the ICD-9s of painful conditions. So it could have been, although not every ear infection is necessarily painful, sometimes they just present with fever, right? So they were, all these patients had painful conditions. This was a study done some years back, so it was around the time of the Joint Commission requirement, so it really wasn't 100% pain assessment at that time, so it allowed us that little bit of extra assessment of knowing that differential between doing the pain assessment or not. I think that's a powerful thing. Just doing that assessment, I think will help you, because I think a lot of times we do use judgment. I think judgment is good. I mean, if you have an obvious deformity, like, this is fine judgment to make the assessment that you need to start with your pain treatment in a certain direction, right? But for a child with an ear infection, not doing that assessment might not lead you in the direction that that child needs as far as knowing what that pain severity is, and then the response to, say, acetaminophen or ibuprofen. I'll tell you too, one challenge that I often have kind of related to ear infections is how to tell parents or how to teach parents to do assessments on pain at home. Because we already know that parents underestimate pain. So whether, and that's from the emergency department perspective. So presumably once they go home, they're still underestimating their child's pain. And it's always been a challenge to me to help parents once they go home to do good assessments of their kids. So I try to, when I, give my Tylenol, ibuprofen recommendations for kids with say minor injuries, try to help them to do pain assessments once they're at home and make them aware that they can underestimate their child's pain. I've done some qualitative work with kids with arm fractures who told us that they often don't tell their parents about their pain that they experience, and will wait until a pain score is 7 or greater before they tell their parents that they're having pain. And most of us would say that we should probably initiate some pain treatment for a known injury like that far before a 7 on 10 is happening, right? So I do try to cue my parents with kids with injuries or painful conditions that are going home, that they need to check in with those kids. The kids told me that they didn't think their parents knew, and I wish I would have asked the parents if they knew, because I'm not sure that the parents didn't know that their kids were having pain, but it might not be true, because the kids were convinced their parents would never know they were in pain unless they told them. So that's another good hint about going home, because most kids are discharged home, and making sure that you have a good pain treatment plan once you go home is important, but a pain assessment plan is also very important.
Yeah, I think that's super important. We've definitely seen all those kids that, were discharged, and then they're like, and they come back in pain, and you're like, well, great. What have you been doing since we last saw you here? And they're like, nothing. Or I took Tylenol 2 days ago, and you're like, okay, great. And then I think the ear pain is important. Like, I hit my ear once, or for ear pain. What are you all using for for pain besides Motrin and Tylenol. Any topicals for ear pain? Nope. Okay, I'm taking one last scroll through the chat. We want to be mindful of our time. We had published the agenda, and I know with all these superstars on the call that folks are going to be tuning in at that time. So we were going to be next up here with Dr. Ali in 2 minutes. So I just want to make sure that we don't have any additional lingering questions or hands. I don't see any hands raised. And once again, want to just acknowledge our medical student ambassadors who've applied to this program for SAAM and are helping us, Joelle Brown and Danny Braithwaite, as well as Becky Berger, who's helping us facilitate the chat today. So thank you all. So once again, next up, we have Dr. Samina Ali. She's going to talk about opioids in our children. First, do no harm. So take it away, Samina.
Thank you so much, Corey, for facilitating this, and to Dr. Drendel for setting us up for a great conversation, because once we have measured pain, what do we do about it? And that's where this talk picks up from. And thank you to all of you who are sharing your day with us. We know it's a long workshop, and there are a lot of competing interests taking these sessions from home or on Zoom. So I appreciate your time and attention. So before I go too far, I'll just acknowledge, as we often do here in Canada, where I'm dialing in from or connecting from, that I'm delivering the session from my home, which is located on Treaty 6 territory, the ancestral and traditional territory of the Cree, Dene, Blackfoot, Saulteaux, Nakota Sioux, and the Métis. And I acknowledge all the First Nations, Métis, and Inuit whose footsteps have marked these lands for generations. I'm thankful to be in this beautiful country that welcomed my parents as new immigrants from another country so they could settle here over 50 years ago. And I now have the honor of being here in front of you today. So what we'll talk about today is in my sort of half an hour or so with you, and then we'll have 15 minutes to debrief about that and share your perspectives and answer any questions as a panel, is to review how and when to introduce opioids into a child's acute pain management plan. We learned from Amy that we don't always need to use them, but we absolutely, there will be indications for them. So when do we introduce them and how do we introduce them? And as we're doing this, how do we understand the risks and benefits of prescribing opioids, including risk assessment? And then learning a 2-minute script to share with families when you're considering prescribing opioids, because I think it's really important in 2021 during an opioid crisis, which is affecting all of North America and beyond to some degree, what the risks and benefits are when we're using these medications. So just before I do speak, my disclosures, I have SSHRC and CIHR are national governmental funding, and WICRI is the Women and Children's Health Research Institute, which is my local research institute. I have received an honoraria from the University of British Columbia, which is the university one province over to the west of us here, over the Rockies, and as a speaker for their university. And I do sit on the National Pain Advisory Council in Washington virtually as a volunteer science and policy advisor. So let's start with our first poll question. When you are treating pain in children, is it associated with A, longer procedure times, B, prolonged ED length of stay, C, lower IQ and emotional resilience, or D, less post-op complications? We'll just let that run.
Go ahead and get your fingers ready and click on those buttons. We see the numbers coming in. Thank you for that. Trying to make these meetings a little more interactive. So we thank you for your participation. Oh, we got some good responses. Give you 5, 4, 3, 2.
Fantastic. So we've got about 90% of people saying less post-op complications. That's absolutely true. Longer procedure times and prolonged ED length of stay were definitely things that people worried about with pain management. And it turns out when when it's embedded within the care path of a child during their visit, it actually doesn't prolong procedure times or prolong ED length of stay, but it's all about when you fit it in. And Dr. Punai will talk a little bit more about managing procedural pain as well. And certainly untreated acute pain will prolong a length of stay because the family won't want to leave if their child doesn't feel better. So let's talk a little bit about why acute pain matters. In the short term, it's longer healing times, longer hospitalizations, more complications, and trauma and suffering for not only the child, who of course is at the center of this, but also for their loved ones who are witnessing them in pain. And we don't often acknowledge this, but it creates distress, moral distress for the healthcare providers. And we know that feeling when a child is, you're trying to do a procedure and they're in a lot of pain, or we're not meeting their needs and they're constantly in pain in the department. It's distressing to witness. It also has long-term implications. And I think these are the ones we sometimes don't think about in the moment, because in emergency, we tend to be more immediate results oriented, right? That's the nature of the type of work we do. But long-term, it can increase sensitivity to pain. So the same injury, the same procedure can cause worse pain later on, increase likelihood to develop transitional and then chronic pain. Care avoidance. So these children can become adults who don't come to the emergency department when their appendix is about to burst because they don't know how to trust their body anymore, because when they had similar pain before, it wasn't treated. So it's probably not important, is kind of what the thinking might be. And then it actually affects brain development. We have some EEG studies and neural pathway studies that show that early exposure to pain can actually change how infants lay down their neural pathways. What about in the ED? Let's come back to our moment right in the emergency department. We are shift-oriented beings. We think about the world in 8 hours or 7 hours or 10 hours, 14 hours, depending on what kind of shifts you do. So in that period of time, it prolongs procedure times. So if you can get Maxilene or a topical anesthetic like 4% lidocaine, which is marketed as Maxilene or methacaine, and Amitop on at triage and on a child anticipating that they will need an IV, you can shorten your procedure times, less attempts. It improves ED department flow if you treat pain. If you don't, it slows it. If we don't treat pain, we have unneeded pain and distress for all the people I talked about, and lower pain and satisfaction scores for families, and frankly, for healthcare providers as well. Now, we don't have great beginnings in pediatrics. We like to be a little bit, smug about how considerate we are of the family. Let's be honest, there's some peds merge docs on this call, on this meeting, and it's not always as good as we'd like to believe. If we go back as recently as 1987, Sunny Anand, Dr. Anand in the UK, published this randomized trial of fentanyl anesthesia in preterm babies. He gave 14 babies fentanyl with paralytic, and 14 babies just the paralytic and some nitrous oxide. So, and the surprise upon surprises, the babies with fentanyl had way, way, way better stress cortisol responses, better recovery times, less apneas and bradycardias, less post-op complications, and got home quickly. But that was 1987. They were doing cardiac surgery and they were not giving fentanyl to these babies intraoperatively. So that's quite recent. Similarly, Dr. Schechter here in the US, when he was in Hartford, did a study comparing adults to children for known really painful conditions. So things like femur fractures and significant burns. And he showed that children were half as likely to get analgesia compared to adults, and that the younger you got, the worse it got. So this is again in the 80s. So we have come a long way very quickly, but we didn't have great beginnings, and we still have lots of work that we can do together. I think I'd be remiss if I didn't talk about the racial disparities in the treatment of pain as well, and the incredible work of Dr. Goyal and her team. looking at children with, in this case, appendicitis. She's also done similar studies for fracture pain and other conditions as well. But in this, showing again the tremendous disparities where the adjusted odds ratio for receiving opioid after adjusting for ethnicity, age, sex, insurance status, triage level, and pain score, you're 5 times less likely to receive an opioid for your appendicitis pain if you are a Black child rather than a white one. So we have lots of work to do. Sometimes I hear this. I hear it's not me, it's them. I offer it. I'm a good doctor, but the family is refusing it. And I've wondered about that too at times. And so along with Dr. Whiston, Dr. Punai, and who's with us today, and a whole lot of other people, we did a 2-center, 750 family study asking the families when they presented with a painful condition. One, we measured where they offered analgesia, and this is across 2 centers in Canada, 2 large pediatric centers in Canada, only 55%. So just about half the children are actually offered analgesia spontaneously by the treating team. And this is not uncommon, and this is fairly consistent across our country. But if they were offered analgesia, so if we asked them, hey, would you like some? 91% of them said yes. So you know what, 9 out of 10 times, it's us, not them. So this suggests that caregiver or child refusal is not a barrier to pain management. So let's look at another question now. Let's move a little bit into what medications we can use and when. So let's say a 10-year-old falls off her mountain bike. She's riding in Banff, which is our beautiful Canadian Rockies, and has an isolated distal tib fib fracture and is grossly deformed. And there's no IV access, and she arrives with 8 out of 10 pain. What would be your first line pain medication option? And there's the poll for you to look at. Our choices are A, intravenous morphine, B, intranasal fentanyl, C, oral oxycodone plus acetaminophen, which is Percocet in Canada and Roxicet in the US, and oral ibuprofen plus acetaminophen. Okay, so looking at our votes here, we've got about 2/3 of people saying intranasal fentanyl, and then we have a little bit for IV morphine and a little bit for our oral analgesia. And this is kind of a question with many possible answers. It depends kind of scenario, but I absolutely agree with the 2/3 who chose intranasal fentanyl, that in the absence of vascular access, intranasal fentanyl will give them really excellent pain management with an 8 on 10 gross pain for the deformed arm within 10 minutes. Intravenous morphine is fantastic if you already have vascular access, but if vascular access takes time, which even in the slickest of hands will take some minutes, then intranasal fentanyl can be given first, and then you can establish the vascular access after. I love combinations of ibuprofen and acetaminophen, and sometimes I use acetaminophen with oxycodone or ibuprofen with oxycodone as well. The problem with those medications in this scenario is they will take a minimum of 60 to 75 minutes to peak. So that first hour will still be quite uncomfortable for those child. So yes, use them, but perhaps not as first line. So let's talk about introducing opioids into a child's pain care regimen. So first, let's talk about very briefly, we did this very recently, just last year. We asked Canadian pediatric emergency physicians what their first line pain medications are. And for moderate pain in green, they said ibuprofen, acetaminophen, and then intranasal fentanyl. And then when it got severe, they switched it up to maintain some ibuprofen and some acetaminophen, but a lot more intranasal fentanyl and morphine. So that's what our colleagues, at least in Canada, are telling us they're using. Let's see how that compares to what families want and know about and what the evidence shows. So we did a similar survey of families, again, across 2 healthcare centers with Dr. Punai as well at his hospital in Canada. And we asked parents, what would you want your child to receive for moderate or for moderate and severe pain? And ranked number 1 was ibuprofen, followed by by some IV morphine, and none of the families commented on intranasal fentanyl. So it just speaks to an interesting gap in terms of their awareness of the literature that we're using, but also probably ties into fears around fentanyl, because when public hears the word fentanyl, they unfortunately probably think of carfentanil, which certainly in Canada, and I believe to some degree in the US as well, is a synthetic opioid far more potent than fentanyl that is used solely for the purposes of misuse. So what can we do when we're treating children's pain? We don't have to jump in with opioids right away. There's a lot of things, and I'd actually add a fourth and first P, if you will, which is prevention. So what all those incredible things our colleagues in advocacy do, putting helmets on children, using protection pads, being the fun police, as my children like to call me when it comes to trampolines. Those things, prevention can actually prevent pain. But if we can't, if the injury or the illness has still happened despite any prevention things, we have physical, psychological, and pharmacologic things we can do. And I think building on what Dr. Drendel was saying earlier, sometimes we think we hear pain and we assume the family wants a medication. And that's not always the case, or that they only want a medication. I think we have to remind ourselves that these three things, these three Ps, work in consort together and should always be used in combination. So my three basic principles for prescribing are use, escalate, add. So I always use non-opioid monotherapy first. I then escalate to non-opioid combination therapy. And if that's not adequate, I will add opioid as a combination therapy. And this is sort of working usually in the mild to moderate range. If we're starting off with moderate to severe, I'm going to talk about that briefly as well, where you might have to jump to the add part more quickly with, for instance, intranasal fentanyl. So first, let's talk about monotherapy. So here we're basically talking about, in most scenarios, ibuprofen or acetaminophen. We do have some other NSAIDs like ketorolac that we do use sometimes, but for the most part, probably 90 to 95% of the time, we're looking at ibuprofen or acetaminophen. So how do I choose, and which one do I choose to use first? I tend to use ibuprofen first, and I think there's a lot of good evidence to support that for acute injury that results in inflammation. So what's the classic injury that children get? MSK injuries, almost, 75%, 80, probably even 90% of what I see in terms of acute injury in children is some sort of MSK injury. And we have fairly definitively put this question to rest through 4 clinics, at least 3 clinical trials, 4 clinical trials now, that ibuprofen should be recommended as the first choice for mild to moderate MSK pain as a part of a multimodal pain management strategy. So reminding us again, if they've got a supracondylar fracture or a radius ulnar fracture, don't forget the splint, don't forget the ice, and then layer the ibuprofen on top of it. You can use acetaminophen as well, but if there are contraindications to ibuprofen, but ibuprofen is always my go-to. And I'm a big fan of go big or go home. So I use the 10 per kilo, not the 5 per kilo. And I max out at 600. There's some adult evidence to suggest 400 is adequate. There's then also some contradictory adult evidence to say we should go up to 800. Neither of those have been proven to be the endpoint for children. So I go with 600. I put a little star there with an infant caveat to remind me that look at your monographs and look at your local prescribing practices. And I'd love to talk about this and in our discussion shortly. In some centers, ibuprofen use at under 6 months of age is not allowed or recommended by certain hospitals. So just be aware of that and know what your local practices are. And that has to do with their concerns regarding safety data for that age range. In Canada, you are allowed to prescribe it per monograph 3 months and up. And in my hospital, we are allowed to use it at all ages with our discretion. I don't get too worried about this because MSK injuries rarely occur in the under 6 month of age group. Anyways, they usually are mobile, so a year and up, and then this consideration is less relevant, but do know your local practice. If we have to combine medications, then I will usually combine ibuprofen and acetaminophen. And the acetaminophen, again, I will dose at the 15 per kilo side. And by combining these medications, we reduce the risk of adverse events. When you're combining with opioids, you actually reduce the total amount of opioid needed. And here's the surprise finding of this systematic review, that ibuprofen and acetaminophen in children with acute pain have similar risk profiles. Because from our adult colleagues, we learn a lot about the higher risks of NSAIDs compared to acetaminophen, particularly for GI complications. And the one we worry about, of course, is GI bleed. Children don't seem to have the same problems when it's used shortly and when they don't have predisposing risk factors. So if I had a child known for peptic ulcer disease, I would not be using ibuprofen as my go-to first line medication. But for the typical healthy child with an MSK injury, would be ibuprofen, and then I'd layer in acetaminophen if I needed it. And I do this all the time for moderate pain, and it works quite well. Now, if we need to add opioids, what do we consider? So the ones that I consider my short list of options are oxycodone, oral morphine, and hydromorphone. The caveats to that are, in Canada, we don't have oxycodone as a liquid. I know it's like it froze on the way up north. We just don't get it. So we can only use oxycodone in tablet form, but in the US, with access to liquid Roxicet, you are able to prescribe that in younger children. Now, be aware that there is an increased risk of future misuse, as we know from OxyContin, because it does have more euphoric effects. Oral morphine was very intuitive for us as pediatric people because IV morphine works so well. You have to up the dose quite a bit because the bioavailability is about 1/4 to 1/3, but there's a lack of demonstrated efficacy for musculoskeletal pain. We have 3 solid randomized controlled trials with over 1,000 children now looking at this. It doesn't work for MSK pain. Does it work for other types of pain? I'm not sure, but someone will likely do the research, and you probably have your own personal experience as well. So I'd love to hear about that if you're open to that later on. And then hydromorphone, or Dilaudid, which is the trade name, comes as tablets and liquid form. It does work very well. It is quite potent, so be very, very careful when you're dosing this in liquid form. And this also has some possible increased risk of future misuse because it is more likely to induce euphoric effects compared to oral morphine. A little bit more about the oral morphine compared to ibuprofen. These are those trials that a couple of those trials that I was talking about. So a 500 patient, 3-center randomized controlled trial suggested that combining ibuprofen and oral morphine did not provide better relief than even ibuprofen alone, also oral morphine alone, but I can't imagine any world in which you would choose to give oral morphine as a single agent if a child could use our oral ibuprofen, because we absolutely know from every study of opioids that has ever been done that they have more adverse events or side effects than NSAIDs do. And then the second trial, led by Dr. Punai, showed that there was no significant difference between morphine and ibuprofen. And again, given that the morphine was associated with more adverse effects, ibuprofen should be our first line therapy. Now let's talk a little bit about codeine and hydrocodone, because you might be wondering why that didn't make my short list. So in Canada, since 2013, codeine has not been recommended for children. Initially it was under 6, then 12, or 12, then now it's been extended to 18, both for pain and for cough and cold preparations. It's been associated with some deaths, and it doesn't work better than ibuprofen. So let's stop using it. Similarly, for hydrocodone, it's been reported to have significant problems for children with breathing issues. So they have now suggested not using it in those scenarios, so obstructive sleep apnea, etc., and not for children under 6 years of age. What about the FDA? So FDA has had some specific restrictions around codeine and tramadol and for use in breastfeeding females as well. So FDA has a contraindication for codeine and tramadol, alerting that codeine should not be used to treat pain or cough And tramadol should not be used to treat pain in children younger than 12. So under 12 years of age, we should not be using these medications in the US either. More recently, they've added a new contraindication to tramadol, saying do not use it after tonsillectomy, adenoidectomy, and this is where they're going to have a lot of swelling and are likely to develop transient obstruction, particularly in their sleep, and there have been associated deaths in this scenario, so it's a no-go. Then lastly, or second to last, a warning to recommend against their use in children between 12 to 18 years of age, both codeine and tramadol, if you have obstructive sleep apnea or severe lung disease. And then again, a warning for the same two drugs for breastfeeding moms because of the issue of the infants having concentrated byproducts in their breast milk and developing excessive sleepiness or difficulty breastfeeding or apnea resulting in death. So what about the child who presents with severe pain? Like that example I gave you, what are we going to do for that child? So we talked a little bit about intranasal fentanyl. I think that is absolutely the way to go. You want to use it divided amongst the two nostrils. So the volume, it says here max 1 ml per nostril, but there's some good evidence to suggest even a little bit less, like 0.5 to 0.75 per nostril is closer to your ideal dose, but definitely not more than 1 ml per nostril. If the volume, now fentanyl, you're not going to get to that volume very quickly, but in some of our other medications that we use intranasally, you might. If you have to do repeat doses to get the whole volume in, give your child maximum 1 ml per nostril, and then a 30 to 40 second break, and then again. So that's one way to do it, just FYI. Always use a mucosal atomization device. Otherwise, what happens is a good amount of the volume will just trickle into the back of their throat, and oral fentanyl is very poorly absorbed. Intranasal is quite well absorbed. IV morphine, of course, and IV fentanyl. We know, and I think we're all fairly comfortable with. Now, here are my principles just in brief again. If you're using ibuprofen or acetaminophen first, use age-appropriate dosing and don't be stingy. And ibuprofen is the first choice for most conditions. Add an oral opioid if needed, but never opioid monotherapy. It should always be along with ibuprofen or acetaminophen and not codeine or hydrocodone based on our best safety evidence right now. If they're in severe or significant pain, think intranasal fentanyl, but this is the one that caught me. I used to make this omission all the time, and I'm getting better at catching myself now, is remember co-therapy. So if you're giving intranasal fentanyl, also give them a dose of ibuprofen at the same time. Or if you're giving IV morphine, give them a dose of oral ibuprofen or IV tramadol at the same time. It is opioid sparing. Don't forget that. We sometimes pat ourselves on the back saying, awesome, I gave them intranasal fentanyl and their pain is so much better. But if you give them an NSAID at the same time, you're going to decrease the amount of overall opioid that they will need. And then when you send them home with a modest amount of opioid. Gone are the days of the 30, 60, or 100 pill bottle. It is a much smaller amount, and a backup plan is essential then, because there will be a small number of children who will need more. So here's another question for you. You are sending home a 14-year-old with a badly fractured fib. You decide to prescribe oxycodone. How many doses are you going to send them home with? 5, 10, 30, or 60? And there's the poll for you to answer.
Answers are trickling in. Keep them coming. Five, 4, 3, 2, 1.
Thanks so much, Corey. And thank you for all of you for participating. It keeps it interactive. I feel like I'm speaking to you then, and we're connecting and I'm hearing you. So about 2/3 said 10 doses, about 1/4 said 5 doses. And I think we're sitting in that 5 to 10 dose range, depending on how bad you think the pain is going to be. We don't want to be prescribing the larger amounts. What we want to do is do 5 to 10 and give them a safety net. There's a number of studies out there about leftover opioids after prescriptions from the ED, and 10 is generally more than enough for them to get through their acute issue. And then if they do need more, That's different. Now, I'm not talking about spinal manipulation surgery. I'm talking about the stuff we do in the ED. So here's another one right away. You are sending home a 12-year-old with a wrist fracture that took 2 attempts to reduce. So it was a difficult one. You plan to prescribe oxycodone along with ibuprofen and acetaminophen, and the mom tells you she has an opioid use disorder herself. You A, do not prescribe any analgesia. B, prescribe a hydrocodone instead of oxycodone because it's a weaker opioid. Prescribe acetaminophen and ibuprofen only, or prescribe oxycodone.
Thanks for participating. A few more seconds.
Okay, so I see here that we have about half of our audience is saying they would prescribe acetaminophen and ibuprofen only, and about 1/4 would prescribe the hydrocodone, and 1/4 would prescribe the oxycodone. So this is I'm actually very heartened to see that their answers are spread out, because this was one that I think it's very much an it depends scenario. So the point of this slide and the next few slides that we'll talk about to round out this talk is, don't assume that because someone in a family has an opioid use disorder that you cannot prescribe opioids. I think sometimes with the best of intentions to protect the child, we say, okay, then time out. I'm not giving you any because I don't want you to develop an opioid use disorder. But if this child has significant pain, and we have tested, for instance, the ibuprofen and acetaminophen in the ED, and we know it wasn't enough, then they will need something. The question will be is, how do we make sure we can use it safely? So I would go with the oxycodone with some modifications in terms of how it's used and dispensed, and taking care of an honest conversation after a risk assessment. Okay, so let's talk about some of the potential risks of opioid prescribing, and then we'll switch over to questions right after that. So there are minor risks when we use opioids, and those are things like dizziness and constipation, nausea, drowsiness. We know those ones, but I will put a star in your minds next to constipation. Nothing in my life have I seen cause more people to stop using their opioids than constipation. So if you're going to prescribe opioids for more than a single dose in the ED, remind the families that they can pick up something like PEG 3350, so Restoralax or Laxaday are the trade names, and use that for the days that they are on the opioids and probably a few days after. Otherwise, they will have such discomfort with the slowed GI motility that they may stop treating their pain. The serious effects, of course, respiratory depression, and the one I want to talk about a little bit more is future opioid use disorder, as this is really difficult for us as emerge docs, especially when we look at a sweet child in front of us, to decide what are we doing and are we putting this child at more risk in the future. So this is the context in which we are prescribing. Nearly 250,000 Americans have lost their lives to overdoses involving opioid prescriptions in the last 20 years. 71,000 of these drug deaths in just 2019 were involved in opioid. And in Canada, our youth, our young adults, are the fastest growing group for hospitalizations due to opioid poisoning. It's a problem. Responsible short-term opioid prescribing includes recognizing that there is some risk associated with short-term opioid use. It is not zero. It also means optimizing pain management using alternative non-opioid medications and those multimodal strategies. Distraction, ice, slings, these things work and can decrease the amount of analgesia, and in particular opioids, that we need to use. And then educating our families and patients on when to use them and how to safely use them. I would be remiss if I didn't mention that we need to do some sort of screening and assessment of opioid risk in children. And I will be the first to admit that I did not do this regularly because it made me uncomfortable, like talking to a 14-year-old and their lovely parents about, do you have an opioid disorder? Well, in Canada, my colleagues who work in substance misuse tell me that it's roughly about 13 to 15% of families have at least one person in their family who has substance use disorder. So that's almost 1 out of 5, 1 out of 6 families that I will prescribe opioids to will have this challenge in their lives. And I would be remiss if I didn't acknowledge it. So I'll ask you this question. Children and youth who have been prescribed short-term opioids for acute pain. So this is that 12-year-old with the tib-fib fracture, the 14-year-old with the arm fracture. They will have a 20 to 30% increased lifetime risk, some increased lifetime risk, no increased lifetime risk, or a 5% decreased risk of developing an opioid use disorder as an adult. What do you think?
Keep those responses coming. A few more seconds.
And you can see here that about 60% of our audience, half of our audience, roughly 50 to 60% believe that there's some increased risk, but they're not sure what number. And about 1/3 thinks that there's no increased lifetime risk. And I'll tell you, up until 3 years ago, 4 years ago, I was in the no increased lifetime risk with short term because I had seen no evidence to convince me that this was true. I have since personally been involved in doing a systematic review to answer this exact question because as it hasn't emerged off, this is what I want to know. When I give that child 5, 10 pills to take home, am I contributing to their likelihood to develop an opioid use disorder? And what we have realized on completing that systematic review, that there is almost certainly some increased lifetime risk, but the way the current surveys and current studies have been designed, we're unable to answer that question definitively. So the Meach studies and the McCabe studies that we've all read and seen, they all answered the question to say there is some increased lifetime risk, but we can't delineate exactly how much. So we need to be aware of this. It doesn't mean that we stop using it when you use, every time you use ceftriaxone or epinephrine, there's also a different kinds of risk, right? So nothing we do is without risk. We just have to recognize there is some risk. So we need to talk to families about this risk and how do we do that without freaking them out. So I won't read this whole script to you. I'm going to tell you where you can find it. But this ended up being my script that I use when I'm treating pain in the emergency department for families, particularly when I expect that I'm going to be escalating to non-opioid use. I do want to draw your attention to the second to last point. Does anyone in your family have a history of substance misuse? If so, let us know and we can help you use this medicine in the safest way. I think that's the line that helps me with the opioid misuse screening and lets the family know that this is an open conversation, not a judgment. All patients and families should have an opioid risk assessment performed before prescribing outpatient opioids. And this is for the safety of the child you're treating, also their siblings, their caregivers, and anybody else who might have access to their medications. If you are discharging a patient home with oral opioids, usually 3 days or roughly 10 doses is enough for the vast majority of outpatient conditions. Encourage families to discuss dispensing options with the pharmacist. So if you needed to prescribe more because it was a more complicated condition, can we dispense them at 10 pills at a time or 5 pills at a time? And encourage the family to return unused medications. That's a very common and acceptable thing here in Canada, where you can return them in an unmarked Ziploc bag back to your pharmacy for safe disposal. Recommend those stool softeners and keep them out of reach and only give as needed. And again, a second reminder, return unused portions to the pharmacy. This is an opioid handout that we created recently for our own hospital here at the Stollery. It's very possible your hospital or other organization has the same. Please do use something like this when prescribing. If you'd like a copy of this, I'd be happy to share it with you. I do provide my email address at the end and do reach out. I'd be happy to share it. The little script that I told you is from the Pain Bottom Line Recommendations from TREC. TREC is an amazing knowledge mobilization network here in Canada, and it has a free app called TREC, and it has all these bottom line recommendations for the most common pediatric conditions, bronchiolitis, asthma, gastro, and also pain treatment. And in fact, this has even been updated as of yesterday. This handout has been updated, and Dr. Drendel is one of the authors for this one. So please do go to TREC and download that app. And if you really find this interesting and want to learn more, please feel free to fire off an email to me or look up at Kids in Pain. This is a knowledge mobilization network specifically dedicated to improving pain treatment for children. So I will stop there, and I would love to hear any questions, comments, reflections that anybody has. Thank you so much.
Fantastic presentation, Dr. Ali. As we look, get ready for additional questions that are being typed into the chat, there was a really great question about that Motrin max dose, 400 milligrams. I was pulling up the paper reference for adults that shows that that study that the 400 milligrams versus the 600 and 800 milligrams. So thank you for bringing that up, Dr. Huang, and I open that question up for discussion.
Did anyone want to comment on it? I can give my thoughts, but I'd love to hear what your experience has been.
I know I've heard in other talks about ibuprofen, and some have said like up to 400 is for pain control. Anything above that is anti-inflammatory. I'm not sure if others believe that or practice that.
Yeah, I've definitely heard the same. Thank you for bringing that up. The two reasons in my mind why I don't stop at 400 is number one, there is an inflammatory component to the injuries we tend to treat in the emergency department because they're acute, usually MSK injuries, and there's inflammation, number one. And number two, children's metabolism and pharmacokinetics of medications are just different as they're growing. And so with adults, where we can extrapolate that they all metabolize and use the medication the same way, with children, it's not so. And we know this, anyone who's given propofol to a 4-year-old knows this. They will use per kilo amounts that would put a horse to sleep, or knock them right out. And these children are still talking to you. So children metabolize drugs differently. And there's no evidence to support stopping at the 400 for children thus far. That's why I still go up to 600.
Yep, I agree 100%. And I put in the chat too, a lot of the times, even just that 10 per kilo dosing, you know, a lot of the times they're using their bottles and they're underdosing by weight. People are Texas sized here where I practice. And a lot of the times they say, you know, your Motrin works so much better in the ED than ours. And a lot of the times it's because they're significantly underdosing. And so being sure to use the milligrams per ml in their discharge instructions, we know those aren't great. And so having a script and having the communication with the family, in addition to their discharge resources, are really great. And I will just second Dr. Ali's reference to the toolkit. I put it in from Trek Canada to put those websites resources. There's a ton of things in the toolkit. They've got some of the best parent education resources on. This is just a video showing how to reduce stress for infants, and then their needle poke. And so other innovative resources, as well as some of those scripts, can be found there. And so as a great resource for you.
I see Jani has a really interesting comment about opioids and prescribing opioids. And Danny says, in the US, there are geographic patterns that underlie the opioid epidemic. Should the specific community or area or region in which you work dictate how you prescribe opioids in the emergency department? And does this change the conversations you have with parents and guardians, or should this change the conversations? I'd love to hear other people's reflections on this. My gut instinct, Danny, is that where you happen to have your injury, where you live, where you experience your pain should not influence what we offer you and what we consider in offering you, but it may change how we dispense it, prescribe it, or you as the receiving family may have different perspectives on it. So I should, as a practitioner, should be mindfully offering it, but having a conversation around whether you are open to receiving it or not. Because there may be a family that says, you know what, it's just too high risk to bring this into my home. We need to work out something alternative. And there's others who may say, I can use this safely in my family by using direct observed therapy and keeping it locked up to protect somebody else in the home from misusing it. But this child with the broken femur absolutely needs to be treated adequately. But I'd love to hear from others if you prescribe in areas where this is a daily conversation. I'd love to hear what you have to say.
And while you're thinking about those questions, I think certainly we've seen from a quality improvement standpoint too, with the changes in rescheduling of some of the different types of narcotics or the liquid formulations, as you really brought up, Dr. Ali, that your pharmacies may not carry it, or your 24-hour pharmacies might not carry it. And so how can you then be an advocate for what is available if you're writing medications? Do you know that the liquid formulation is available for children? And how can you work with your area pharmacies to understand that, or have a dialogue if there is a shortage or they're running out, just so that your system has a process in place for adequately treating pain. So I think that is really important. And we know drug shortages plague many things.
Yeah, I will say, I know in the big database studies, there are definitely regional differences in prescribing practice. Like universally, the East Coast prescribes opioids at a much lower rate. And in my personal studies, multi-center studies, they are much lower prescribers compared to the Midwest and the West Coast. So it's interesting how much opioid prescribing is a kind of a cultural thing versus something that's truly specific to pain assessment or injury type. I'm not in, it'll be interesting to see how that ultimately affects outcomes, and especially in relation to the opioid epidemic.
Yeah, in a session we did a few weeks ago too, Dr. Drundle and I surveyed the audience, and people's practice changed drastically from where they trained to their current culture. And so I think knowing the environment and knowing what's available, and then thinking about that really important question of safe disposal. Do you know where your safe disposal is? Are those resources provided on your handouts? Do you talk to your families about that, or is there scripting around that as well? Are really important topics that were brought up.
I think what I've learned the most over the last 2 years, really spending time in this space with what is the risk with using opioids for children in short term, is that I need to get over my discomfort having uncomfortable conversations. So doing risk assessments and telling the parents honestly, you know what, there is some, I used to say without any hesitation 10 years ago that you do not get, these were my exact words, using opioids for pain management will not cause addiction. Short-term use of opioids in the emergency department today for your appendicitis will not cause addiction. I'm not sure I can say that with complete and utter certainty. Does that mean I'm not using opioids for severe appendicitis pain? Absolutely not. My practice hasn't changed. My conversations have changed. And when I say my practice hasn't changed, I mean for those severe in ED cases. Do I think more critically about how much and when I give opioids for going home? Absolutely. Yeah.
Okay, and then I want to be mindful of the agenda that we set out today. As a reminder, we are leaving this 15-minute break, depending on which coast you're on. Dr. Drundle Ali and Punai, Drs. Drundle Ali and Punai will stay on this call if you guys have any questions, but feel free to keep your cameras off, turn your cameras off, take a break, do a stretch, do some mindfulness exercises, and take care of you. It's going to be a long week, and we are really delighted that you've taken the time today to join us. So please, we will resume in 15 minutes from whatever time zone you're in. But feel free to ask any questions, turn on your camera, let us see you all. And otherwise, please feel free to use this time.
Corey, do you think the format's been working for us as far as questions? Can we, Danny and Joelle and I, be helpful in any other way to you all?
I think that's great. I'm so fortunate. And like I said, congratulations to our med student ambassadors. I know it's a competitive program and you applied and are doing exciting things. Danny and Joelle, do you want to tell us a little bit about yourselves?
Sure, I don't mind. So I'm Danny. I am an MD PhD student at UNC Chapel Hill down in North Carolina. And so I am in the long haul. I am in year 6 out of 8 or 9 years of this program. So I'm currently finishing up my PhD before I go back to medical school. But all of my research is in pediatric care in the emergency department. And so this is kind of my sweet spot. I'm also really interested in mental health care. So my hope is that by the time I get back to med school and finish my rotations, I will figure out from what avenue I want to tackle that in the long run. But I have a strong interest in tackling it from the emergency medicine perspective.
Fantastic. Specifically, what is your research on?
So I'm doing my PhD in health policy and management and public health. And so I am looking at how we provide psychiatric care to kids in the emergency department, specifically interviewing practitioners in the emergency department, as well as looking at electronic medical record data to see how we're doing.
Fantastic. Yeah, the mental health crisis is extremely problematic and challenging, and both the EMSC for Children Innovation and Improvement Center, as well as EMSC in general, is vastly committed to mental health, as is Trek Canada, and are trying to create some really great disciplinary tools and strategies, as well as lots of great funding opportunities for those areas. So congratulations, great work. Joelle, are you on, or did you pop away? No judgment if you guys are actually using your water and break. She may have stepped away. And then we're excited to have Dr. Becky Berger, who's been assigned to moderate us as well. She is a pain and sedation dominator from Children's Healthcare of Atlanta. Becky, do you want to say anything?
Hopefully you don't hear the microwave in the background. Haha. But yes, thank you, Corey. I am happy to be here, and of course, Corey and Amy and I have been working extensively on pain and sedation. So I'm excited to moderate and hear all your thoughts. I'm really learning a lot and enjoying it. So thank you for having me.
Yeah, and I guess I'll definitely welcome Becky and our Pediatric Emergency Care Applied Research Network, PCARN Pain and Sedation Committee, is not a closed committee. So if you're interested in joining us and having more dialogue around pain and sedation, Dr. Drendel is one of our co-chairs. So we are excited to always talk about pain and sedation topics and try to maximize research as well as quality improvement and ultimately the care of children. I will take a second to grab water, so I'll let you all self-moderate for a second.
So, one of the things I thought was interesting was your discussion about oxycodone versus hydrocodone. It seems very regional, like where I trained in the Midwest in the United States, they were very much into oxycodone, but now I'm on the East Coast, it seems more hydrocodone. And I think maybe it's related to kind of local pharmacies, but again, I'm interested to hear what others use.
Yeah, the hydrocodone thing is interesting. When codeine became fell out of favor, some people jumped on the hydrocodone train in Canada as well. But when you compare hydrocodone to codeine, it doesn't have any better potency or better responsiveness to my understanding. I'd love to hear from Amy and Naveen if you have any thoughts on that. So I worry about our using it kind of the way we use codeine, as opposed to oxy, which seems to have a little bit more potency to it. Amy, do you have any thoughts on that? Because I don't use hydrocodone.
Yeah, I think there is hydrocodone supposed to have higher potency than codeine. So it's kind of the level between codeine, hydrocodone, oxycodone. But the volume of hydrocodone is huge and it tastes horrible relative to oxycodone, at least with the US volume standards, because typically the oxycodone is kind of a 1 milligram per 1 ml. I think hydrocodone, if I recall correctly, it's like 2.5 milliliters per 1 milligram, if I remember correctly. So you end up getting like 2.5 times the volume, which doesn't sound like much fun either. So, and not as powerful, for better or for worse though, right? So it's interesting practice variation.
I'm not sure if it's Mia or Maya, but has a very interesting question, which I'll put out to our panel as well. With regards to opioids, do you dose children based on ideal body weight if they are obese? And I think for IV opioids, for sure, if they are reaching adult weight, for instance, and they're opioid naive, I wouldn't go by the milligram per kilogram dosing. I'd max out at adult doses very quickly and start on the smaller side of that, more because they're opioid naive than anything else. Amy, any comments on that, or Naveen?
Yeah, I agree with that as well. And if you start with that ideal body weight dosing and you reassess then after your expected pharmacokinetics, right? And you find that you haven't reached that goal, then that'll give you a sense of what your next step might be as well. So I think better safe than sorry, right? Because the alternative is then you're giving Narcan, which doesn't sound like a good idea. Very excited that we have such an engaged group. This has been good.
Yeah, it's lovely. And we've been holding pretty strong at 29, 28, 29 throughout the session. So that's lovely. And they are filling out the polls, which is wonderful too, because that's a good measure of if they're tuned in or not. I know if I'm not tuned in, I miss the polls, right?
It's hard to imagine how we can get a bunch of emergency providers together in one place for this long of a period of time. So you guys are incredible audience.
Yeah, we really respect your OCD challenges to try to doing other things and multitasking. So you guys are staying on the polls. I am secretly timing you and making sure you're answering in appropriate time. No.
All right, now that Corey's back, I'm going to sneak away and grab something too. So I'll be right back.
Absolutely. And if Joelle jumps back on, we can have her tell us a little bit about herself too. But yeah.
Hi, I'm here.
Yay. Hi, Joelle. Welcome. We just let Danny tell us a little bit about herself. We had no judgment. We told you to take your breaks. We want to get sure you get the
no worries. Danny and I were splitting the session. So she took, she's on the East Coast, I'm on the West Coast. So she took the first half and I got myself ready and woke up a little bit. So
yeah, no, fantastic. We a lot of the times don't respect the time limits of our West Coast colleagues. So welcome. Tell us a little bit about yourself. What year are you?
So I'm actually MS4. I just graduated. So I'm technically an MD, I guess now. I'm not used to saying that. I went to St. George's University in the Caribbean, and I actually matched in a pediatrics residency. So I applied both to EM and PEDS programs and ended up matching into PEDS. So I will be starting my residency at Case Western Metro Health in a couple months.
Fantastic. Congratulations.
Thank you.
Many of us did PEDS first, and so we are excited for that.
Yeah, no, there's a finding my people in the little intersection of PEDS and EM. So
yay, welcome.
Thank you. And thank you, Dr. Mitzman, for the shout out.
Yep, huge congrats to all the trainees out there doing their training in this interesting year/years. It's been a challenge, and we are so excited to have you all join our ranks, and hopefully as we move forward to a more normal environment.
It made for a very interesting application season, to say the least.
Yeah, I think here for sure we saw many more state applicants end up staying as well, just because you knew what you knew.
Yeah.
And it was a little bit more of a risk with the virtual interviews.
But I think it was a challenge for me, at least. So SGU has us make our own. I schedule my 4th year, so and they have a lot of different. Since we're an international school, we don't really have our own home, so to speak. So I had to do a lot of scheduling and rescheduling because different sites had different restrictions for students coming back to clinical rotations, and there were different requirements. So it was a lot of there was a lot of flexibility. In some ways, it was an application season tailor-made for EM applicants, because there was a lot of changing plans on the fly, so to speak.
Revolving Zoom rooms, we can do it, tag team it, just like the ED, in and out, in and out.
I've got very, very good at Zoom. Whether I wanted to or not, you figured out Zoom pretty quick.
Okay, any last questions in our minute of free time? We once again will have questions at the end of Dr. Punai's session, and at the end as well. We just really do appreciate your interactivity and typing those questions in, and sticking this one out with us, because we were a little bit nervous and looking at the schedule to do this virtually, and we are just so overwhelmed by the engagement and the thoughtful questions. So thank you again. And we'll let Dr. Punai get his slides up into presenter mode, and then I will look for any last hands, any last thoughts. 5, 4, 3, 2, 1. All right, take it away, Dr. Punai. He's going to be talking about what analgesia options do we have in this acute post-codeine era.
Thank you very much, Corey. Thanks for you guys for being here. This is the 7th inning of this workshop, and I hope you're enjoying it. I also wanted to say that it's my distinct pleasure to be here presenting with Corey, Samina, and Amy. They're really the powerhouses in pediatric acute pain and implementation science, and I'm very privileged to learn from them and work with them. I think I figured out, with Danny's help, Danny and I have been working in the background, how to get that video to play. So I will hijack that video and put it on shortly. Just before that, though, I am Canadian, and I would like to do, like Samina did, a land acknowledgement. So I acknowledge that Western University is located on the traditional lands of the Anishinaabe, the Haudenosaunee, the Lenapehoik, and the Attawandaron peoples, on lands connected with the London Township and Sombra Treaties of 1796 and the Dish with One Spoon Covenant Wampum. This land continues to be home to diverse Indigenous peoples, First Nations, Métis, and Inuit, whom we recognize as contemporary stewards of the land and vital contributors of our society. So let's see if this is going to work. Oh no.
Still no audio.
Still no audio. Okay. I'll try again. So about 10 years ago, the US FDA and Health Canada put advisories in place over the use of codeine in children under the age of 12. And depending on where you live in the US or Canada, there's also similar advisories placed around the world. And the reasons were multifactorial, but involved some case reports of serious adverse outcomes, but also the detection of receptor polymorphisms, cytochrome P450 polymorphisms. So what that's done is it's led to a gap in the ability to manage pain in children. We have overcome that gap to a large extent because a lot of people and a lot of institutions have supported funding and supported research projects to identify new and innovative ways of caring for children in acute pain. And we're going to be talking about some of these. I'm going to frame a lot of what I'm going to say based on the American Academy of Pediatrics recommendations in 2012, when that position statement was re-supported. And we'll talk about a few of these things, and some of these things will have actually been touched on by Amy and Samina, and will be rounded out by Corey at the last hour. So let's focus a little bit on musculoskeletal pain. Well, we know that MSK injuries comprise up to a fifth of pediatric emergency visits, and it's still the case where more than 40% of these kids are not receiving adequate analgesia. This word here should be inadequate. I apologize for the typo. And we might be giving them analgesia at triage, but they're not necessarily getting it for their x-ray when their arms are being manipulated. And they may not be getting it at discharge either. And pain is often rated as moderate to severe. And it comes as no surprise, and this is from some of Amy's work, that a lot of children are still experiencing pain when they go home. So what don't we know? What we don't know is how do we shorten the time to analgesia? From when the time they get registered to the time they're in a bed, that could often be several hours of pain for a child. Are opioids better than non-opioids? Well, some of Samina's work will hopefully answer that question in the next year or so. Can oral morphine replace codeine? Officially, we don't think that's the case. Samina's presented some work, and I will sort of present some additional work to answer that. And is there a role for intranasal therapies? And I'd like to talk a little bit about that today. So, the things that are really, really helpful for kids, and I always like to start my talks off with non-pharmacologic therapies, because these are things that we learned from our grandparents, and these are things that we can all do, either at home or in the ED. And there is actually evidence, good evidence, for immobilization for children with fractures. We know that it can significantly reduce scores on the FACES pain scale if fractures are immobilized. We just actually completed some work in London in our Southwestern Regional Network on ambulance call reports. And we found that when kids actually have a visible deformity, it was a negative predictor of receiving a splint. This was entirely surprising to us. And when we engaged our paramedic colleagues, they told us it's because they don't want to touch the arm when it's visibly deformed. So it's really important that we change the way that this is approached, even for pre-hospital providers, as well as in the ED. Sylvie LeMay is a pediatric pain researcher in Canada, and she did some of the initial work on ibuprofen for MSK injuries. And in contrast to adults, where ibuprofen has been found in large systematic reviews to be not superior to conventional or to other analgesics, including opioids, we know that for mild to moderate pain, we can actually get about a 25% reduction in pain at 60 minutes, so at an hour. We know also that it's better than acetaminophen or codeine in MSK injuries, and it has fewer adverse effects. Amy Drendel, I think, believed or had some foresight that that codeine was going to receive some bad press, and she did some of the earlier work on looking at ibuprofen compared to acetaminophen with codeine, so the combination of acetaminophen and codeine, and she found that it improved functioning for children with MSK injuries. And we know that it's at least as effective as combination acetaminophen and codeine. And of course, not unexpectedly, more adverse effects in the acetaminophen codeine group. So we can see here that on the FACES pain scale, a lot of these kids are coming in with 4 to 6, even 8 to 10 pain. And if we can get that down to a 0 or a 2 on the FACES pain scale, then we've done a pretty good job. What about oral morphine? We asked the question earlier, can oral morphine replace codeine? Well, we wanted to know that specifically for MSK pain. And we found that, Samina touched on this, is that it's no better than ibuprofen, but it was associated with more side effects. When we look at tramadol, and most of us know this already, there is an FDA warning to avoid its use in kids under the age of 14, and in particular, those with potential for respiratory depression. Who are those kids? Those are kids with, primarily who are post tonsillectomy. And opioids such as oxycodone and oral morphine, although they may be effective to some degree, they do have the greatest risk of CNS side effects. So it's important to give families that information so they can make an informed decision with you. Samina has stressed this multiple times, is that opioids really should be added to rather than replace non-opioids for kids. So whenever I give this talk, people always ask me, so if you saw a child come to your emergency department and they had a visibly deformed fracture, would you give them, and they were screaming in pain, would you give them acetaminophen or ibuprofen instead of morphine? And the answer is yes and no. So what I would probably do is the fastest therapies to give them is actually a non-pharmacologic therapy. So I would make sure that that broken arm is splinted, because once you splint a broken arm, it feels a lot better. So if you splint the arm, and then I would get some ice, and then I would give them a non-opioid. And the non-opioid, in addition to the splinting, should reduce the pain by a decent enough amount where I could do an actual pain assessment reliably. And I would give them additional therapies for times when I know that they're going to be in more pain, but knowing that once that non-opioid is on board, I will be using less opioids going forward. And the opioid of choice in our setting would be intranasal fentanyl because it's relatively safe, can be given in a non-invasive way, and it's short-lived, and you can give additional doses if need be. So that brings us to intranasal fentanyl. There's actually 3 fairly rigorous pediatric studies that show it's effective for moderate to severe pain. This is the dose that we are using here, and we can see that it's associated with about a 40 millimeter pain reduction on that 100 millimeter visual analog scale. And we think that it's equivalent to IV morphine for traumatic MSK pain. It does have some mild adverse effects, but they're not as pronounced as with IV morphine. Intranasal ketamine has been increasingly published in the adult literature. Can we use it for children in MSK pain? Well, there was a study published 2 years ago, a small study, but it was very well done, and it was in JAMA Pediatrics. And they actually showed that it was non-inferior to intranasal fentanyl for moderate to severe pain. This is the dose that they use, so 1 to 2 milligrams per kilogram. Remember, this is probably the same IV dose that you may use for reducing a fracture. But at intranasal doses, the bioavailability is only at 30 to 40%. And they were able to get a 30 millimeter reduction at 30 minutes with an effect lasting about an hour. Importantly, though, there were more adverse effects. So this study included a sedation scale and found that children who received intranasal ketamine were more drowsy or sedate with it compared to intranasal fentanyl. Now, what's important to take away is that there's still a gap in the literature. we still really don't know how to get their pain with an MSK injury, when it's rated as moderate to severe, down to less than 30 millimeters on that visual analog scale. Why do we care about 30 millimeters? Well, that is sort of where the World Health Organization tells us that pain can be adequately managed and a child can return to their activity when pain is less than 30 millimeters. So I'm going to ask for the first question in my slide deck. A 5-year-old female with a fractured distal radius. All of the following are recommended except splint placement, intermittent application of ice, ibuprofen plus intranasal fentanyl for more severe pain, or manipulation with imaging for this with the splint alone.
I believe in you. We've a few more answers. We're just highlighting your interactivity. We like it. Let's give you 5 more seconds.
Okay, great. Yes, so most people chose manipulation for imaging the splint alone as a do not do, which is great. So everybody's paying attention. So I'm just going to close this out. So let's talk a little bit about nitrous oxide. So I've gotten to be a little bit more interested in nitrous oxide of late. It's probably because one of my senior colleagues asked our group to do a systematic review. So I've actually been reading about it a lot more, even though we don't have it at our center. I'm sure some of you do have it at your own centers. So it would be great in the chat to get some questions and comments about that. What we do know from my extensive literature search is that it's used for a variety of, mildly and moderately painful procedures. What are these? Venipunctures, laceration repairs, and a lot of dental procedures. But what we also know is that it has insufficient evidence as monotherapy. So for things like fracture reduction by itself, it doesn't seem to be as effective and analgesic. In combination with other agents, such as intranasal fentanyl, it may be more effective. And now it's also a good point to remember is that most reviews done to date and most trials will stress the importance of patient cooperation with nitrous oxide. Let's switch gears here and talk a little bit about abdominal pain. Abdominal pain is one of these things that it often frustrates us as emergency physicians because of the risk of missing a surgical diagnosis. And often we get these cases that they're not surgical, but the family's wondering if it's surgical, and it's been going on for a long time. So we get a little bit anchored to the idea of, could this be functional? Well, most cases are functional in nature, and it's really striking to know that less than 2/3 of kids receive analgesia in the ED, and half of these kids experience ongoing pain following discharge. Not only are these kids in pain following discharge, but a lot of them are coming back to your ED and increasing your recidivism numbers. We were interested in looking at non-opioids for functional abdominal pain. And this trial was published last year where we looked at hyoscine butyl bromide, which is the trade name is Buscopan. And some people don't have hyoscine in their EDs. I'm not sure if it's available in the US. I had some of my American colleagues tell me when we did publish this work that they don't have hyoscine in the US. Well, we do have it in Canada. You can get it in the ED, and you can actually write a script for it as well. And it's used by a lot of the pediatric gastroenterologists. Well, both of these agents, hyoscine and acetaminophen, they actually received, they attained a 50% reduction in abdominal pain at 80 minutes. So a lot of these kids started out at 60 minutes, and then it came down to 30 minutes, which we like, with very few adverse effects. The important point, though, is that this study was not designed as a superiority, was as a non-inferiority trial. So we don't know that if it's no worse. And we also did not put a placebo group in this trial. So there's been a lot of comments that, well, if we didn't treat them with anything, it would probably get better and they would go home. I'm not sure if I believe that. Sometimes children go home and they're still in pain, and I think that's what the literature generally shows for functional abdominal pain in children. So I think providing them with the armamentarium with parents of empowering them and role modeling that we're going to assess pain and that there's an option for a non-opioid in the ED will translate into providing effective pain management at home. When we look at appendicitis, it is really the most common pediatric surgical condition, and typically your pain is progressive and it's severe, and that's why they end up in your ED. But we are getting better. So, about 10 years ago, even at my center, our pediatric surgical colleagues were telling us not to treat appendicitis pain. And that has really, really changed because we're now almost universally treating pain with appendicitis, just as you guys are doing in the US. But what's important is that about a third of these kids don't receive analgesia until after diagnostic imaging takes place, which can take a long time. So are opioids effective in appendicitis? Well, yes, they are. They can provide up to a 40 millimeter decrease in pain reduction, but they're not consistently effective. And what's important, what the take-home messages is for our surgical colleagues is that whether we give opioids or not, there's actually no increased risk of delayed management, abscess formation, perforation, or any other complications. There is some small studies that have shown favorable results with IV morphine in appendicitis, and many of us are uncomfortable with giving morphine to children because of risks of respiratory depression and hypotension. Well, when we're giving morphine to children with appendicitis, very often we're trying to fill these children's bladders using parenteral fluids anyway. So it's much less likely that you're going to have issues with blood pressure control in children if you give them morphine. And the evidence is pretty strong that says if morphine is given, if you titrate it to effect carefully and use standard dosing, the risk of respiratory depression is extremely low. And this is consistent with AAP recommendations for severe pain. However, having said this, this slide is up here, but partly because I'm a Game of Thrones fan, but it is up here because I just wanted to let everybody know, in addition to this, it's really important to use non-pharmacologic, non-opioid strategies as a first line for kids that are relatively differentiated. So obviously, if they're coming with a very painful abdominal presentation and you don't know, could it be a stone? Could it be an ectopic pregnancy, a ruptured ectopic pregnancy? Those are different kettles of fish. But for pain where we kind of know that it may get better if we provide a non-opioid, or we think it could get better with a non-opioid, I will often try IV ketorolac first as a non-opioid, and that will hopefully decrease the amount of opioids I have to provide to these kids. Let's look at procedural pain. So there's an abundance of evidence, and it's a persistent body of evidence that infants' pain is poorly managed, even compared to older children. And we know that overall, children's pain is poorly managed compared to adults. The damaging part of this is that most ED procedures, painful procedures, venipunctures, IV starts, urethral catheterizations, lumbar punctures, they're actually performed on neonates. And these little ones go through moderate to severe pain, and they're much less likely to receive analgesia. Well, fortunately, the agent that has the most evidence behind it is also the one that's probably the most benign, and this is sucrose. And there's many studies published extolling the benefits of sucrose from mild to moderate pain. We know that it's effective in children under a month of age, and it may be effective in children up to 12 months of age. And the effect is enhanced with non-nutritive sucking. So this is the marketed product. I'm not showing you the label of the marketed product here. But you can have this marketed product. If you've got it in your ED, great. If you're not, if you don't have it in your ED, I mean, we don't have it in our ED, and we just use a little bit. We use 2 cc's, 1 to 2 cc's of D25W on a pacifier 2 minutes prior, which is the recommendations. In terms of non-pharmacologic strategies, again, I really like to go back to these approaches for infants who are undergoing painful procedures. So this is a very well-known Cochrane review, and they focused on heel sticks and venipuncture. And we know that the strongest evidence is for non-nutritive sucking, swaddling, and rocking. There is good evidence for breastfeeding in neonates, but for moms that aren't breastfeeding, non-nutritive sucking with a pacifier is also very beneficial. For older kids, obviously we wouldn't want to be doing things like this, but distraction using with the assistance of a child life specialist or even an empowered parent, bubbles, toys, pinwheels, music, and of course for the teenagers, technologies and tablets are a good way to distract kids. But it's also important to provide anticipatory guidance to family members. And I can't stress how important that is. I usually talk to families very, extensively at the beginning of a procedure, being cautious of time, of course, to tell them what their child is going to expect, and also how they can comfort their child. And to get a sense, I ask them, what makes your child comfortable? And sometimes that reminds parents of what they need to do to comfort their child, because when their child's in the ED, they're often quite stressed, they're overwhelmed, they've forgotten all of the things that makes their child happy. But when you can engage them in this way, it empowers them to do what they can to comfort their child. Upright positioning in the lap, again, always really, really helpful for even, children up to early school age to minimize pain and anxiety. When we look at lumbar punctures, I'm just going to come back here to lumbar punctures. I often get this. I often ask my trainees, how would you provide some comfort measures for lumbar punctures? And they kind of look at me quizzically. And I think a lot of them believe, at least I believed, also when I was a trainee, that if I gave sub-Q lidocaine, or even if I, put something over the skin, that it might obscure my landmark, and then I would be having less procedural success. And there was also the argument of 1 poke versus 2 pokes. Well, we know that local anesthetic, that providing local anesthetic, it consistently leads to improved LP success. So that argument of 1 poke versus 2 pokes is probably not as strong, particularly if you're giving local anesthetic either topically, and the AAP recommends sucrose, or topical agents, which is LMX or 4% lidocaine, or subcutaneous lidocaine. You can give that with a very, very high gauge needle to minimize the distress that the child experiences. And it's also important to combine sucrose with that. We did some survey work a couple of years ago across Canada's pediatric tertiary care centers, and we actually found that physicians were significantly 60% less willing to use local anesthetics in infants compared to older children, which is very striking for us. So my second question for you guys is, a 4-month-old female requiring a lumbar puncture, which of the following are acceptable analgesic options? Non-nutritive sucking, swaddling, topical anesthetic, and I've specified here 4% lidocaine, injectable sub-Q lidocaine, sucrose solutions, or all of the above.
Keep those responses coming.
Okay, great. So you could have picked anything here and it would have been correct, but all of the above obviously includes everything here. So that's great. What I do personally is I will give the child some sucrose, and I will use a sub-Q analgesia, because I find it really makes them nice and comfortable. And I will reliably tell parents, the parents often, balk at the idea of a lumbar puncture. And I will often tell them that, little babies, they dislike the IV far more than they dislike a lumbar puncture, in my experience. It's probably because it's technically much more, well, the region is much more superficial compared to in an older child who we may choose to sedate for a lumbar puncture. In terms of venipuncture, this is probably the most common procedure performed across age groups in children, and it can be associated with significant distress. So when we say distress, it sort of combines two spheres of pain and anxiety, which we may not be able to separate. Topical anesthetics work great for pain, and depending on what you use you may not be able to relieve distress completely, because there's still a very prominent anxiety component. Now, this Cochrane review actually does support breastfeeding during the procedure, but if the mother doesn't breastfeed, then certainly sucrose or human milk on a pacifier are both equally effective. The device I've put here is called the Buzzy device. So this is a neuromodulation device that works on the gated pain theory. And there is some industry-sponsored studies and also some independent studies that have looked at this and found it to be effective for things like bedside glucose checks and intramuscular injections. We've gotten a little bit more interested in intranasal dexmedetomidine. So IV dexmedetomidine is used widely in the ICU setting. At this point, it's a very expensive drug, but in the ED, some centers are actually using intranasal dexmedetomidine. We looked at this and found that it safely provided adequate sedation at a superior level than conventional sedatives. And what do we mean by conventional sedatives? Midazolam, so oral or intranasal midazolam and oral chloral hydrate for non-painful procedures. For painful procedures, though, there's still a lot more study that's needed. Let's look at urethral catheterization. So urethral catheterization is one of the most challenging aspects of management of pain. And we know that intraurethral lidocaine, in contrast to adults, is probably ineffective. There is some benefit for sucrose in kids under the age of 1 month, but less so. So the question is now, are we performing too many urethral catheterizations? Well, there's a lot of literature out there saying that bag specimen collections under the age of 5 months are not only poorly sensitive, but they're poorly specific. And certainly if you use them in older children and they've stayed on too long, then the specificity wanes. And if they're positive on the bag, then you may have to do the catheterization anyway. So can we avoid urethral catheterizations? Well, there's been a couple of studies that have shown that there may be the ability to stimulate the bladder externally and allow the child to do this, which is pee into a little cup in a sterile fashion. This is one of the first studies that was published, and their contamination rate, I believe, was up to about 15%. But some centers I know are using this, and I think in Edmonton at Samina Center, they are using a similar approach to this, which is great. We haven't made that quite yet in our center. So Samina may be able to talk a little bit more about this. One of the things that we're very proud of is using the Comfort Promise. Some of you guys are using it at your centers. As you know, it was a lean quality improvement initiative that was developed at the Children's Hospital of Minnesota, and it's been adopted by several US and Canadian pediatric EDs. And our focus here with the Comfort Promise is needle-related procedures and using these 4 simple steps for all children undergoing needle-related procedures. Laceration repair, apart from venipuncture, of course, by physicians, it's the most common procedure performed in the ED. And we are using topical anesthetics, which I'll talk a little bit about there, but it doesn't do much to relieve the procedural distress. And a lot of young children, like this little guy depicted here, they're quite combative. And this may compromise the cosmetic results depending on the level of trainee that's doing the laceration repair. And more importantly, though, it predicts adversarial reactions for future visits, not only from the child, but also their caregivers. And conventional sedatives, such as midazolam, they're inconsistently beneficial. So we know that they work great in some kids, and in other kids, they just don't work that well. There is good evidence for LET, or what we call lidocaine epinephrine tetracaine. Remember that that it has to adhere to keratinized surfaces. So if you can bring the wound together, that's great. Or if you can bring the hair together, that's great. But if the wound is gaping and open and you can't bring it together, I'm sorry, I misspoke. LET is an anesthetic. I was talking about glue. So I'll go back to the anesthetic of lidocaine epinephrine tetracaine. It works very well. It needs to be applied for about 30 minutes to an area like a face. But on a joint, it's generally better to apply it for as long as 40 to 45 minutes. It doesn't wear off. So as long as it's on the affected part, it's continuing to work unless it's dried out. So as you can see here, this little guy has it under a piece of Tegaderm, and as long as it's there and it's dry, it will work. You can also use subcutaneous lidocaine, but obviously that's a little bit more painful, and you can mitigate some of that with bicarbonate. LET doesn't penetrate deeply into the wound. So some people will recommend that you put a little bit into the wound and then you put another piece on a gauze and put it adhere tightly over the wound to get it in. The best approach, though, is to avoid the suture. So this is what I was initially talking about before I misspoke, was tissue adhesive. So skin glue or steri-strips, and there's various trade names attached to those there. I've put one of these here, but without the trade name attached. There is no increased risk of poor cosmesis with skin glue, but it's important that it follows the lines of scarring. So down through here and down through here on the other side are those lines. Obviously less painful, no removal is needed. There is a higher rate of dehiscence with skin glue, but this can be mitigated with application of steri-strips over the glue. Now, what I was mentioning there is that we generally don't use skin glue over joints unless it comes together well, and when they flex and extend the joint, it doesn't dehiss. And it only adheres to keratinized surfaces. So if you really can't get the skin together, your glue is not going to take. Light sedation for laceration repair. There is, again, as I mentioned before, inconsistent evidence for oral or intranasal midazolam. From this small study done by Neville's group, intranasal dexmedetomidine was studied against intranasal midazolam, but they only focused on positioning, so they actually didn't focus on the actual repair. We're conducting a dose-finding study of intranasal dexmedetomidine to find the best dose. I believe Neville used the dose that was at the lower end of the dosing range, but there is some evidence for intranasal midazolam plus intranasal fentanyl in combination, and a lot of centers are using that. This is not a clinical trial. This is actually a retrospective review that showed it is beneficial for laceration repair at these doses, but we don't have any objective data on distress or sedation. So we're planning to look at that in some future work at our center. My third question is a 2-year-old male with a dog bite to the face. What analgesic options are available? So distraction, topical anesthetic, meaning LET, ibuprofen, acetaminophen, or all of the above. And if we could have the question, please, that'd be great.
Thank you. Can y'all see that?
I think it's
It was the wrong one. And I think they got a little out of order. 1 second, I'm trying to pull it up.
Or just go ahead and type in the chat. Type your answer in the chat, A, B, C, D, or E. For distraction, topical let, ibuprofen, acetaminophen, or E for all of the above. A 2-year-old male with a dog bite to the face. What are your options?
And it looks like most people are picking E, which is great. Yes. So these are also all good options, and usually we use a combination of them. And the absolute necessary thing is let, but it may not be sufficient. Good. And this is my favorite slide. I left this one to the end. These needle-free injection systems, which we do not have in Canada, but you guys have them in the US. The one I've pictured here is called the J-tip. It delivers subcutaneous lidocaine, jet injection using compressed carbon dioxide. And some work has shown that it's equivalent to topical anesthetic cream for LPs. So with that, I'm happy to take questions, and it was a pleasure talking to everyone, or having a chance to present to everyone today. And I look forward to the questions.
Thank you so much, Dr. Punai. That was an invigorating conversation and a huge, really engaged chat. So as I'll give you a minute and let you look through some of those questions, there's just so many where to start. But really, really great adjuncts taken, some that people are using, some that they're not. I think I'll just start with the nitrous oxide. Yeah, we're using an RED. I typed that, the AGP discussion is a little bit controversial. I'll put a statement from the Society for Pediatric in regard to sedation in regards to that topic. But we definitely use a lot of nitrous oxide. It's fantastic for difficult port access as well. And like I said, our nurses can use it at 50% or less for IV placement. I don't believe that there's a magic cutoff for minimal versus moderate sedation, but it's what our regulatory folks were able to get through and approved. And then it also vasodilates. So in our extremely difficult access patients, it does a really great job of vasodilating those veins and making that easy as well. So I'll open it up to any specific nitrous oxide questions, or if anybody has comments or questions to add in that regards. We did do a study of PEMNAC chiefs, which it was the North American chiefs of the US and Canada EDs. And it does seem like a lot of them use nitrous oxide in a freestanding device versus in the wall, but both systems are available, and we're always happy to answer questions about that. I do want to make sure we get a chance to talk about the hycosamine. Looks like you had a lot of good questions about Naveen. Do you want to expand on any of those specifically?
Well, I'm seeing a question here from.
Did you just see Elliot just asked, when do we use nitrous versus intranasal Versed? If we want to address that before moving on.
Yeah, sure. So, I mean, we don't have nitrous in our ED. So my choice would be to use intranasal Versed, but I use it in combination with intranasal fentanyl, just because the evidence isn't strong for it. We're planning to do that in a trial, next year. So I wanted to gauge to see how effective it was, and I find it fairly useful for laceration repair. We're using more intranasal dexmedetomidine for laceration repair as well. There's been some practice creep from our pilot work. So nitrous, yeah, we don't have it in our ED, but I think if you have it and all you have is nitrous versus intranasal Versed, I would probably go with the nitrous oxide, as long as it wasn't a very painful procedure like a fracture reduction, in which case I would use another analgesic modality with the nitrous oxide. Remember that intranasal Versed, or intranasal Versed is a trade name, but intranasal midazolam does not have any analgesic properties, and it may have a paradoxical effect in children for anxiety reducing. The other question I have here is, do you prefer intranasal Versed over oral Versed? So I found oral works better because of reports from patients at intranasal versus burns. Yes, you are correct. So intranasal midazolam does burn. That's one of the things with it. And if you need to give it, sometimes the child will really remember the burn and they might actually sneeze it out so that you have less bioavailability, significantly less. But the bioavailability from an intranasal dose is greater than with an oral dose. So that's just something to think about.
Related to that, too, it's the onset is quicker with the intranasal versus the oral, and I think I find that people use the intranasal. They give it and then they set their things up and then they can get started because onset's 5-7 minutes versus waiting that 20 minutes for the oral Versed. A lot of things could come up and pull you away, and you might not be able to get back in. I do find that nitrous is nice for older kids because there's top doses for Versed or midazolam at some point. And the nitrous will allow you to go with older and older kids, which is a really nice attribute of that in general. I have used midazolam and nitrous together. It just gets you a little bit deeper and might allow you to be a little bit more successful. There are some kids with nitrous that get very uncomfortable, whether it's the mask or the disinhibition, they get anxious with it. And so the addition of the midazolam helps with that.
Yeah, and I think the other thing with nitrous is that we get used to doing a lot of things in the ED and a lot of things with ketamine, and we lose the principles of a calm, nice, tranquil sedation setting. And I feel like that definitely needs to use some of those one voice techniques and guided imagery with the nitrous to really get them where you'd like them to go. And so I think those are really great points, Dr. Drendel. And the other thing I'd note, like you said, is really you're looking at a 1 milliliter volume per nair. And so that's what she's talking about with tapping out those doses. And that can get us into the same place too if we talk intranasal ketamine as well, depending on the dose you're using. And then in regards to that, I would like to note that intranasal dex does not burn at all. I've got a great video of it being, administered several times to kids, and that does not burn. And so, as was noted by Dr. Punai in regards to Dr. Neville's study, she did use that a little bit lower on end of the dose, which I agree is lower than we like to start with that 2 mics per kilo. And I think the other thing that would have made her study more dramatic too is if you wash out that wound and then put your lead on and then give your intranasal dex, then they're nice and sleepy. And I recently had 2 medical students take probably 45 minutes to stitch up. No offense to the medical students, but it was a very complicated facial laceration, but the child slept through the entire thing. So really great adjuncts with intranasal dexmedetomidine. And if you're not using it, it's another great tool for the toolbox.
Yeah, and I know, Corey, so you put that Neville used 2 mics. Yeah, you are correct. He did use 2 mics versus 0.4 of midazolam. And from our dose finding work, the dose finding study is actually very interesting. It's done using some very advanced statistical methodology where you'd use 3 doses at the lowest dose, and then you plug it into an algorithm, and then you go up to the next dose. And what we've found, again, this is just our center because it's a very small study, is that that we didn't get much effect for the actual laceration repair with 1 and 2 mics per kilo, that we actually had to go up to 3 mics, and now we're at 4 mics per kilo. And we don't plan on going any higher than that. There's a good question here, Becky Berger. Are you all seeing a lot of abdominal pain due to cannabis abuse? Yes. We're seeing more and more of it. How are you managing it? We're seeing it in the context of vomiting, which cannabis hyperemesis, which we're all aware of. And yes, we do use capsaicin. I will say that I'm trying not to laugh when I say this, but you have to be very good about the discharge instructions because you can get it over the counter in Canada. And a young man was told to use capsaicin And we have no idea how this happened, but he returned to the ED a few hours afterwards, and we had to flush out his eyes because he put it on his belly, and then he must have rubbed his eyes and it went in his eyes. So you have to tell them that, you have to be very clear with them that this burns. So you have to wash it off your hands before you rub it in your eyes. But yeah, we do use it. There is some evidence for it, and that's how we manage it. We don't use haloperidol, but I know there is some evidence for that as well.
Yeah, and Dr. Berger reminded me privately in the chat, just the comment about the Dermabond too was brought acutely to my mind as my child did get some intranasal adjuncts for his laceration repair of his forehead, at which time he then proceeded to come home and try to spray his siblings with the remainder of the squirt can, and then walk straight into a pole because he was still a little bit disinhibited from the intranasal medication. And so he did have to get dermabonded. So no problem with the initial laceration repair, had a great experience. And then the dermabond, because I was not going to take him back to the ED, huge tears and crying just because the warmth and the exothermic reaction, he just did not at all like the feeling of that. So something to think about, warning the child or making sure you have a good second set of hands stabilizing if you're not doing sutured repair, to think about the glue as well, and just prepping the family in that regard as well.
Phil asked a question, is that the combination of hyoscine and Tylenol, sorry to interrupt you, Corey, or separate both achieve the 50% reduction? We didn't combine them. Good thought though, well, we didn't combine them. And the max dose we used of hyoscine was 10 milligrams. But I know in the adult world, they're using higher doses at 20 milligrams. So separately, they achieved a 50% reduction.
And really great tip by Dr. Mitzman to give him a bunch of gloves and send him home for the capsaicin application.
Yeah, that's a really nice tip. We should do that. Great tip.
And then that J-tip question was really great to bring up, Dr. Punai. That was on the PEM listserv last week as well. Are folks using J-tip or Zingo or other lidocaine application intradermal devices?
I need to get on that PEM listserv, Corey. I've heard so much about it.
It's a good one. Well, I'll put it in the chat.
And I apologize again for the video not working. I don't know. I'm going to play with it.
And then super quick minor correction. Desi Neville is a girl. You mentioned his study, but it's a she. So I'll just.
Oh, I'm so sorry about that. Yeah, my mistake. And there's another one upping this question since it came out earlier. Hyoscine, do you use? Yes, we are using hyoscine butyl bromide in our ED for abdominal pain. I usually tell them it takes about 80 minutes to work. And if I deem that the pain is not surgical, I will quote the results of the study and say that acetaminophen was just as effective. And I will give them the option of remaining in the ED or going home and then coming back if it's getting worse. And I'll give them a dose of acetaminophen in the ED. Another question here, are people using droperidol to treat pain in pediatric patients? Personally, we don't have it, so I'm not. I don't know if anybody else has it and they want to comment.
Really fantastic discussion and questions here. I just want to looking back through those chat, making sure we're getting all of that. And then there's a question to you, Dr. Ali, from Dr. Ali to Mia, how are you using it in your ED? If you can unmute or have that capability, or just type in the chat if you get a chance.
Yes, hi, let me see if I can. Hi there. Thank you for the talk. And so I have a lot of emergency medicine residents, that come through our pediatric emergency department that love droperidol, and they want to give it to all the pediatric patients for, you know, headaches, maybe some abdominal pain, maybe the hyperemesis, abdominal pain with the cannabis use. And I'm just wondering, you know, if it's being used in other pediatric emergency departments, because a lot of my emergency medicine residents use it on the adult side. And me, I'm a pediatric trained PEM physician and did not train with droperidol. So I'm just wondering if there's evidence that it's effective in children. Because I when they're closer to an adult age, you know, we get an EKG and then I'm okay with using it. But I was just wondering if anybody else has been using it or has any evidence of how effective it is in children.
Is that specifically for cannabis, abdominal pain and hyperemesis, or in general?
I'm sorry, can you repeat that?
Great. I was just wondering if they're using droperidol for cannabis related abdominal pain and hyperemesis, or if it's in general for other causes of acute pain that you're referring to.
They've been using it, from my knowledge, in patients who have not only with the cannabis use, but also it's like pain and anxiety. So at least in my experience, when I'm working with these residents, it's what they've been using it for.
Yeah, I'm an EM/PEM physician and I do half and half, and we are not just using it on the adult side for cannabis, we're using it for all kinds of intractable nausea and abdominal pain with good success. The peds literature is all anesthesia based. So like, I know that it's out there. I think it's like somewhere in the like 5 to 7 number needed to treat for reducing like post-op vomiting and things like that. But we don't use it in our PDD. I think the anesthesiologist may use it, but it's not something that's available to us in the department.
Great, thank you so much, Dr. Mitzman. That's a really great point. And I think I just put in the chat the PEM listserv. So it's a fantastic repository. There's all those archived ones. So no need, Dr. Punai, to feel bad about not getting on sooner. There's archived discussions, and it's a really fantastic place for questions I didn't know I should have, and keeping up to date on some of that. I definitely recommend for all the trainees.
Thank you.
Yeah, that's a really great discussion. I really want you to keep those questions coming. We still have some more time for Dr. Punai. I know I'm keeping my list of, I've got my next 20 years of studies written down after today's discussion. And I look forward to partnering with everybody on this call in regards to those coming forward. So let's think about what other ones too did we have, or any thoughts? And then I'll just note too, in regards to nitrous, there's several ambulances in our area that do use nitrous from the pre-hospital standpoint too. And that's been fantastic. Before we got nitrous and RED, and you saw the nice deformed fracture, I'd ask them to keep the nitrous oxide going from the trucks and reduce the fractures there. Yeah, so that's thinking about all of these adjuncts from a pre-hospital standpoint too is great.
Along those lines of pre-hospital stuff, how many of you all are seeing the EMS crews administering ketamine, like intranasally or IV for pain?
Most of our paramedics in our region are PCPs, or what we call primary care paramedics, as opposed to advanced care paramedics. So that's the PCP is between an emergency medical technician and or emergency medical attendant and an advanced care paramedic. So our PCPs are about 70 to 80% are PCPs, and they are not allowed to give ketamine. So
I will say in Milwaukee, our paramedics do use ketamine for a number of for both agitation and sometimes for pain, as we've seen it come in. I think the biggest challenge we've seen around it is if it's a multi-injured patient, then it's hard to tell whether they're head injured and altered or just ketamine altered. So we've been definitely working with the team to make sure that we understand the patient's status pre-ketamine, which can be challenging for sure. I don't know if you've seen similar problems.
Yeah, I'd say, Amy, that's the main reason they don't like to use it here in the trauma setting is the altered status. Once the patient's condition is understood or their head's been scanned, it's different. But first blush, they prefer to avoid it for that same reason. I was going to mention methoxyflurane, which we didn't talk about today, but just in case anyone hears about the green whistle from Australia and New Zealand, it's used in their pre-hospital system quite extensively and in pediatrics as well. And it's inhaled anesthetic in a little green plastic dispensing system. That's one system per patient, and they can administer it themselves until it's finished. And the idea being that it's not an opioid, but same as ketamine, it's not without its risks for misuse as well. But it's just been licensed in Canada about 3 years ago, and I think we're going to start seeing it being used more.
Yeah, great talk. We have not been using it. I haven't seen it as much, but I've been following it on the research side, trying to see what patient population folks are using it in. And then I just did put in the chat from the EMS for Children Innovation and Improvement Center. We have PEAK toolkits, and we're partnering with Trek Canada on several of these toolkits. The mental health is undergoing evaluation, and so we touched on some of those topics, and I think that too is what, as Amy mentioned, we're seeing some more ketamine pre-hospital, and then in the next 2021-22 year, pain is on the docket for our next toolkit update. So we're really excited about that, and we'd love to partner with y'all on any of those toolkits, and so that's just another opportunity. Last question, time for any additional questions for Dr. Punai. I think we got through most of the questions from the chat, and then we'll have a joint session at the end of this last, and Eddie too as well said the ketamine EMS is using quite a lot. When we look at the evidence in kids from a pre-hospital, especially from a mental health standpoint, you know, the evidence is kind of all over the place, but that is good. Any other hands? Questions that we didn't give you enough second to unmute and ask? And I like Danny saying she found her people. So yeah, we're excited to partner with all of you on this exciting work to manage pain in kids. So this, like the rest of our session, is going to be interactive. And so just give me a quick thumbs up if you're seeing my screen okay. Okay, awesome. Fantastic. So this part is how do we bring this practice, all these great things you've heard about. Like I said, I've got just notes and notes of pages on things and to integrate into our practice and opportunities. And so we want to make this all about you and want to think about how can we integrate some of these things we've seen, because you've heard from these great pain influencers on different kind of projects. What's the evidence? How can we do this? But really want to think about step one is we've made you a little bit more where some of these things may be, or things that you have already been doing, but how can then we take it that next step and integrate it into your setting? Because we're excited if you start prescribing and using some of these mechanisms, but we want to try to think about how can then you become the next innovator, and we can be sharing your studies on our next innovation of this. So be ready to type in the chat. We've got some interactive questions for you all. So in regards to that, have you participated in pain-related studies? And then let's just launch that poll.
This one unfortunately won't launch. I launched this one earlier, thinking it was the other one.
Oh, yeah. Sorry, that was my mistake. So we can just answer yes, no. Have you guys done pain studies? And then if you really will take the time to start writing in some of those studies, either you've been doing or been thinking about doing, because we do want to make the session interactive and use as a brainstorming opportunity. So we are seeing some answers. Yes and no. Great. So type in the studies you have been working on, and then if not, then start to think about anything that's generated discussion today, and we'll be sure to use those in the chat and as fodder for discussion and throughout this talk. And then if there's an opportunity for improvement in pain management in your studies, what would you look at as areas to improve? Would you want to do an opportunity looking at pain assessment and reassessment? Do you even know what pain scale you're using in your ER? Or do you use just whatever the nurse documents? Do you think about if it's the right age population for that child? And so we'll just launch this poll if you can check. And I think you should be able to check all that apply, but no problems if not, just pick your favorite. Improving time to pain medication. Maybe we are noting there's certain populations or appendicitis, MSK pain. What do you want to improve your time management in some of these patients? Do you want to add an additional route? Are you using intranasals, sub-Q injections, those types of things? Adding an intervention for pain management. Are you using topical lidocaine or injectable? And then if not, then we can add some more options. Great. And then I'm taking it that the other 20 of you who already have optimized pain management, and we need to learn from you. So I will look for your all comments from the in the preceding or in the rest of our talk here. But yeah, opportunities to improve pain assessment and reassessment. Really, we did show that assessing and reassessing pain does improve pain treatment, but is that a bad thing? By asking about pain, are we doing a better job of managing it? So when we look at what type of prescriptions, as Dr. Ali and several of our panel had mentioned, across the country, this was using medical expenditure panel surveys in the earlier 2000s, but looking at what procedures do patients receive opiate prescriptions for. We saw that trauma was a very large one, making up a lot of that procedures. And so depending on how the coding, the MSK injuries could fall into either of those categories. And then dental was another big area of opioid prescriptions initially. And so when we look at my setting, we looked at that as well. And we did find, as they did, that MSK complaints were that large category. Shoulders or joints dislocations and fracture reductions were an area where the pain management opportunity. So I was looking at your local data and seeing where your prescriptions or pain management lies is great. But as far as a good starting point, you can use some of the data that's been done and that we talked about today. And certainly in a study just done recently, published in Pediatrics out of the University of California, San Diego, they as well looked at opioid prescription on ED discharge as an opportunity for quality improvement intervention. As with pain management and pain science, is rigorously rooted and good research. So is quality improvement studies. So this is by no means meant as your overall quality improvement primer, but an opportunity to really think about how can we take the principles and practices that we are talking about and improve the care in your EDs. So this study did, and they get into the weeds, but the orthopedics were their top two areas where they were currently prescribing their opioid Medications, once again, they did have oral lesions and dental as another place that was extremely painful and opportunities to improve on opioids. And then as far as the medications, we can look at what type of medications are we prescribing? Are we prescribing the right opioids that are even available in a liquid formulation or a tab? Do you know if your patients are filling your medications? Are you the ones getting the callbacks when those medications aren't available? Or are they coming to your, whatever your triage system may be? But how are they getting the medications? When we, there's been several regulatory processes improvements in both the US and Canada and legislation to change opioid practice with the epidemic. And one of those was in the US was the rescheduling of hydrocodone containing products. So within our health system, we are really interested in seeing one with hydrocodone coming down, were we going to see a rise in codeine that we were really worried about? And keep in mind, this was earlier in 2014 when that rescheduling happened. And so we did overall initially see a bump in codeine, which was extremely concerning to us. And so then we could drill down on that because we knew that at least from that same Medicare expenditure data, codeine was the largest prescribed opioid earlier in this decade. And so those are some of those other ones. Hydrocodone was high oxycodone, but we had seen that codeine still, we had a big opportunity for improvement. So as we've reiterated several times, and if you have one other takeaway from this talk is don't use codeine, we'll just say it one more time. Dr. Tobias and the crew from the American Academy of Pain Medicine and the Committee on Drugs came out with a statement, by the American Academy of Pediatrics, Health Canada, many institutions don't use codeine. We still see it. We still have patients transferred in who have received codeine. And so I think that is one great step, tramadol as well. So when we're thinking about our quality improvement measures, we really want to think about those SMART aims. You're really invigorated, you're ready to head to your next ED shift and integrate all of these things. But we really want to try to think about how can we improve from a system standpoint, and maybe even in your health system, as some of your EDs may be in health systems where you can really have the opportunity to impact change and evoke pain. And then maybe too from just with every EMS arrival, every transfer that you have an opportunity to affect that system. But you really want to think about aims that are specific, measurable, achievable, and realistic. And then they're time bound. You just don't want to improve your use of intranasal fentanyl overall. You want to do it by X% over X months and those kind of things. So this is just an example. Key driver diagrams are not meant to be scary. They should be pretty simple. So it's really just what drives or contributes to that achievement of your project aim. And you may start listing those out and get to a dozen, and that's just too many. Your key driver diagram really should stick to 4 major items that are actionable. And so this is just once again, from that recent pediatric study where they were looking at decreasing the number of opioids prescribed, total number. And so they said their global aim was just to prevent opioid abuse and addiction. Well, that's great. That's a great aim. But then how do we really drill down and make action steps to get to that aim? And so you want that aim to be SMART, like we talked about, which is what they did and is so nicely displayed here. So they looked at the total number of opioid doses prescribed weekly, and they wanted to reduce that by 50%. So for them, using their baseline data, go from 153 doses per week to 76. And then, like we said, in a time-sensitive metric, they wanted to do that over 4 months. They then talked about the 4 ways and that they could really get there. And so they wanted clear guidelines on the discharge opium prescribing. They wanted to standardize training. And so awareness and education are almost always a part of some of the interventions involved. And then they wanted to be able to look at those outpatient pain control as far as if they're returning. We got to look at those balance measures now that you're not prescribing as many as everybody coming back the next day to get more opioids, or are they calling their PCP or subspecialists to get those prescriptions. And then we want to look at patient satisfaction. A lot of the times, satisfaction scores drive a lot of things in healthcare, and we know that pain management is a big satisfier as you look at things that made your friends or family, or even with the care of your own children, upset with management. I think providing that timely pain management is usually up there. And then the electronic medical record is not going away. There's a lot of us are on the same electronic medical records, and so we don't need to recreate the wheel. And we can use some strategies that have already been developed. And then as far as specific education interventions, how do you really get there? What works in your system? What is going to be that way to best do the knowledge translation? How can we make it default to the right amount of medications? Well, that can be an easy fix if you're not able to prescribe, or you have to go through hoops to prescribe more things. It might be easier to prescribe an appropriate amount, and then be able to look at that data and iterate. And so the next slide shows that weekly report of opioid prescribing. So they did from August of 2017 through August of 2019, over a 2-year period. They looked at their doses of opioid discharge instructions. They integrated a hospital guideline and handout, and then defaulted their electronic medical record to 5 doses. Could be overridden, but that made a nice big improvement. They then did the educational poster and provider feedback. A lot of the times to get to those baseline metrics is giving your provider specific feedback. So what kind of route can you actually deliver that information safely and non-judgmentally, but get the information to the provider that, hey, your prescribing practices are outside of that of the rest of our group. And then making sure we orient new providers. We have a Baylor way of doing things. You guys may have institutional specific ways, like we talked about, and how can we better orient folks consistently? And then thinking about, can we optimize those liquid volumes as well? So maybe we took care of the tablets, but our liquid prescription amounts set in the appropriate default. And then can we work with the subspecialty teams that might be driving these interventions as well, and really try to get to that improvement? So this was another intervention that they looked at jet lidocaine, like Dr. Punai referred to, so that JTIP lidocaine, they wanted this process conducted by a quality improvement study and conducted by Dr. Jane and his colleagues, looked at what would get us to a place where we might be able to use jet lidocaine. If you guys were listening to this talk earlier and you think that this might be a way to go, they felt that, wow, maybe for our situation, standing order would be great. If we could, for every IV placement order, there's an opportunity to put that order for the lidocaine, then that would really do it. How then can we also integrate that education? Why are we doing this with that evidence sharing? And then we'll need some staff education around that, and then come down to a policy. If it's policy, then maybe we have a more likelihood way of happening to that. And then we got to educate our families as well. The pop of that injection may be scary. How do you talk about it and educate the families that this is a standard? Do you want to work with the hospital? Maybe it could be a hospital intervention. So there's lots of ways to work with some of those different kind of strategies, both the pharmacologic, the psychologic, and our adjuncts in regards to adequate and optimized pain management in your setting. And keeping in mind that it's never, some of these items may not work for 100% of your patients. That's usually our goal, isn't 100% for a reason. And thinking that we do have to be patient and family centered and reflect that art of medicine as well. And that all patients may not fit into these modalities. So looking at intranasal fentanyl was a lot of great comments in the chat for this talk about using intranasal fentanyl. It's something we've been really excited to try to think about here. And we know that studies out of Milwaukee, they were able to improve pain management to get their opioids in within 15 minutes. When they started this policy, they were able to look at it, given it triage. They had no side effects in regards to oxygen desaturation or other concerns that might surround that. And so that they were finding that policy really improved care. And they saw that 75% of the children that received the intranasal fentanyl had a 2-point reduction in pain scale. So that was pretty awesome. We know from data from the PCAR network, the Pediatric Emergency Care Applied Research Network, when we were looking at our sickle cell study for one of our ongoing studies now, it was preliminary data, but we looked at what the centers were using, and we saw that for those centers that were using intranasal fentanyl, the median time as an interquartile range to first opioid for patients receiving intranasal fentanyl versus no intranasal fentanyl, which is just IV morphine primarily, that we did see 25 minutes to IN fentanyl versus the over an hour for IV morphine. And we know that with the guidelines for sickle cell management, we should be under an hour, and we weren't quite doing that with the IV opioids, but we're able to get there with intranasal fentanyl. We also then have to look at those balance measures. Like we said, are these patients still able to go home? And then do they stay home? Do they come back right away because they got their pain reduced faster, but then weren't able to have their pain managed? And so we did see that the admit rate for intranasal fentanyl was much less, that 49%. And then when we looked on this bottom graph of were those patients, this was the were they admitted or not, but then also did they come back? And so that was a really great study. And then a study out of Dr. Berger just put in the chat one of the studies as well. And then there's also a study of Dr. Fine out of hospital in New York that looked at that as well out a couple of years ago. That was a great study looking at intranasal fentanyl use in that chronic pain population, which is fantastic. For us here, we used that opioid prescriptions here at Texas Children's. We did look at opioid prescriptions as a quality improvement metric, and we were actually able to use our maintenance of certification within the American Academy of Pediatrics to get credit for this quality improvement initiative. And so we looked at those opioid prescribing less than 3 days, which is the CDC recommendation from the Center for Disease Control, and fitting in alignment with all the evidence that has been presented here today. We wanted to get our codeine to 0. That was an easy marker. We had already gotten there with the evidence, but made sure that we weren't seeing any bumps. And then thinking about that instructions for safe disposal. At first, we were trying to use our own ways of creating an add-on to the electronic medical record. And then we thought about that and said, why are we doing this on an individual basis? If we prescribe an opioid, you need a discharge instruction for safe disposal. It should automatically do that. How do we make that happen? So those two were really easy or easier measures to integrate. And then thinking about those balance measures, right? Once again, not looking at bounce backs and return visits to the ED for poor pain control or to their telephone encounters, primary care doctor, specialist visits. And this was our time metric. We saw that last summer in the midst of the pandemic, right when we were having a surge here in Houston, we did start to see longer opioid prescriptions. When we looked at the data, that was a lot specific to the fact that return visits were difficult, and we had a clear reason for that bump. But then getting back to what was going on, and then once again, or that was right in the midst of the, or sorry, this was last year, and then here was our little bump with this summer's visits last summer of 2020, looking at those bump in the musculoskeletal injuries. Here was just that rise in our traumatic visits, having our summer trauma season, as many people pre-pandemic experienced, and then looking at why that was, and then we're able to bring that back down in partnering with our orthopedic colleagues and other things. So here's just another one looking at your pain management metrics, trying to think of some other ways. This was a study done by Dr. Iyer. They were initially looking at that time to IV opioid back in the early 2020 to 2010s. But this could apply to metrics you might use for intranasal fentanyl or any of the other interventions you might use. They were really wanted to see within 45 minutes of arrival for patients with long bone fractures. Once again, that MSK population is usually a large volume, largely painful population. That might be a good place to start with your department specific initiatives that, you might want to just say that pick 90% of those patients. We want to get adequate pain control. And then how do we do that? We need to just work to standardize that initial assessment and the type of injury, sharing awareness, standardizing orders, and then aligning all those resources and personnel and equipment. And so those were their key drivers. Once again, we see from their early 2007 that they were able to baseline had about 20% of their patients received an IV opioid within 45 minutes. And then that went up to 70% once they started their bundle. And then really once they got to their specific education around that, and then they saw too that they weren't adequately capturing it on their electronic recording the way they had done that. But then when they really did their patients were manually reviewed by their team, they saw that they were up in that 90% range. So great work on improvement and some great just examples of an aim and a key driver that you might think about. And then satisfaction, we mentioned that quickly, but patient satisfaction scores are patient satisfaction, pain management has been tied to satisfaction scores. So as far as a way that improves overall patient satisfaction, and that might be a metric that's important to your department, that's another really great reason to do pain management for our patients and families, as well as for your visibility. If that's something that helps your department get a good quality improvement study done, then I think that's a great for everybody involved. So when this study by Dr. Iyer as well showed that then for their fractionary patients that they were able to adequately get to that consistently to that 90% of them within 45 minutes, they saw that the patient satisfaction scores over that time period were much higher than their overall patients that had a pain medication delivered. And so pain management is important. It's important for many, many reasons, as we've talked about today, but for satisfaction as well. And that's been consistently reported in the literature that child's resolution of pain is really one of those statistically significant correlates with a satisfaction. And so for many, many reasons, adequate pain management is fantastic. So here's our just last question talking about quality metrics. We've kind of touched on some of these things. Which ones do we usually use in pain studies as far as metrics? Outcome metrics, process measures, or patient and family perceptions? So if somebody can launch that poll, thank you. So outcome metrics are looking at just those a lot of the times did we have a decrease in pain score and improved pain versus the process that it's just a time to medication, time to pain score documentation, and then our patient and family perceptions. And once again, I just really thank you for your interaction on these polls and throughout this talk. This has just been a really fantastic opportunity to learn with you all. Perfect. So interestingly enough, and I think rightly so, as far as what we should have as outcomes is, was that pain truly improved, and did it make an improvement for that patient? Unfortunately, when we really look at quality studies, the primary outcome has been process measures. And so I think we do need to get to looking at those outcome measures, and patient and family perceptions can go into those outcome measures too, especially if it's the patient's report. But overall process measures have dominated the literature, at least in the quality improvement studies. And so this is a fantastic study across from our friends from the North. Dr. Tull Friedman and her colleagues in Atlanta wanted to look at their health system. And so for children with a limb injury that got greater than or equal to 1 dose of analgesia, how could we really look at that? Because overall, the baseline data showed that only 28% of kids with a limb injury received analgesics from their data. They wanted to improve that. So they did a survey that looked at how, what was the current practice. She did a grand rounds on the topic, talked about educating the staff, looked at staff comfort. How can we get better and more timely pain management? And then how can we develop kits and signs and flyers and education around that, and then promote pain scales so that we can optimize that pain management. So they started at their main children's hospital. And so like the US, we've got a lot of quaternary and tertiary care centers, but then there's large, the vast majority of kids are taken care of in non-children's hospitals. And so how do we work within a system to improve that? And so here we saw that over her time period from April of 2014 to March of 2017, they started to look at that first in the Children's Hospital in Alberta. And so they saw that, their target was this 40% of the visits had for those complaints had analgesia. They were at initially a 28% median. And then most of the time their time to pain management was 37 minutes, and they really wanted to set that marker out at 15 minutes. So they introduced their interventions that they talked about on that last screen. They were able to get that percent from 28% to 37%, and down from 37 minutes of time to get that pain management within 18 minutes, which is just awesome. And then they rolled it out to 3 general EDs. So not just in their primary quaternary hospital, but their affiliated 3 general EDs. And so with that implementation, they did get that analgesia up to 40% and above 40%, and then time to pain management in 12 minutes, which is really just awesome when we think about the ability to manage pain. So our next slide is for you. And let's go back to look at that chat. Did anybody give us a pain? And here's your interactive part, folks. So we know it's getting closer to the end, and we do have time for dedicated questions here in a bit, but I do want to see what kind of these pain interventions have you done? And let's just see. Dr. Ali had one. Does anybody want to unmute and share one of their AIM statements, or maybe just in thinking about from this talk earlier today about things they want to maybe improve? I think that commitment to comfort is a really good one. So let's think about what would be an AIM statement. You can type or you can unmute for either oral analgesia or intranasal fentanyl at triage. Ooh, and I do want to touch base a little bit more. I want you, both Dr. Punai and Dr. Ali, to jump in on the quick wee process too, and catheters, not cats. We're not talking about cat pictures today. Thanks. But yeah, so what would your AIM statement be? So let's think about, for 90% of patients presenting to the ED in pain, we want to administer oral analgesia within X minutes, or I want to increase intranasal fentanyl in X time. Let's take about that comfort promise and needle pain. Who wants to tell us what would be a AIM statement? And there's no right or wrong answers here. If you're currently using it in 0, maybe using it adjuncts in 10% might be a great start. So anybody want to have a AIM statement around that? No, and that's okay. We can talk about some of those drivers. I think that education, that EMR optimization is super great. Here's a great one. So compliance with the bundle. So once you have an education bundle, we want to use that in at least 50% of the patients. Primary driver might be the fact that we want to control people's pain. We want to not have these long-term hospital and medical avoidance because of their traumatized experiences as children, and all of those things. So those are really, really great. And then you can think about secondary drivers of that and what interventions might work. But once again, I implore you not to recreate the wheel. We want to, utilize things that are available. So a lot of people are on the same medical systems, Cerner, Epic, all scripts, and so there might be some built-in optimizations that might even be super easy to do. But this just will provide a slide that would kind of help you with that. One of our electronic medical interventions that we worked at is we really wanted to get better at pain assessment. We saw that while on some of our tracer studies, we were 95% compliant with our pain assessments within 30 minutes of an IV medication and 60 minutes of an oral medication. I had some concerns about the data. And so we went and worked with our data specialist to really think about how, especially in the analgesics and opioids, are we timely assessing pain, or are we? And so we had to do some detailed work with our data specialists to really kind of drill down on what were those times, what were those medications we wanted to look at. And then we really needed to refine those, because Motrin and Tylenol are given for a lot of other things, including fever, anaphylaxis protocols, pre-medications that were not pain related. And so did you have to have a pain assessment after those? No. And so we wanted to make sure we were accurately collecting that data. We then optimized that and then implemented it, and really needed our data, our clinical teams to really look at that and then be able to capture all the different places in the medical record and the flow sheets in every different institution, because we're really good at recreating the wheel and customizing that we're not capturing all the data consistently. And so then we were able to work with the inpatient and EC team, the infusion center and clinics that had brought to attention like the pre-med protocols that we weren't initially thinking of. We were able to think about the process for fever identification and a temperature documented within X amount of time, or if it was actually clicked for fever as an indication, and trying to look at those therapeutic duplication orders, how we could do that. But the infusion center brought that other list of times these medications were used, looking at diagnostic imaging, operating room, PACU. So making sure that we did capture all of our sites was really important. And then as far as where we were looking, we needed dashboards that were responsive and could be immediately clicked from the homepage. So everybody with access can click to it from our main Texas Children's page for the unit leaders and look at this data on a daily basis. And so this can be refined. So this is 2021 data. If I look at our 3 main emergency center visits, we see that on this day, we were about 38% compliance. Okay, maybe that's pretty good. But what was going on here in our main emergency center with the 21%? And how can we look at these different datas? How is it different based on shifts? So if evening shift is consistently, or vice versa, better about time documentation, how can we work on little cycles to try to rapidly improve that? And then can we drill down to by specific provider and provide them that feedback on a dashboard, and that can really improve our management. And so there's lots of ways to do this. And you guys have heard a lot about the PDSA cycles, that plan, do, study, act, but make that commitment, innovate, and then rapidly think about it. So we were able to build that dashboard, really engage local representatives to say, well, we document in a different mechanism, or ours is only on the handheld device that the nursing uses in our unit. And so we're able to really do that through one of our phases, then validate it, making sure the right people had access, making sure that there was that commitment to improvement. How do we maximize that improvement? They get a note from their supervisor about what their pain management documentation is as well. And then understand, is it important to leadership? We've gotten to a certain level, but if it's really going to be a priority for the leadership and prioritized within all the other competing responsibilities and the things that this year has thrown at us, how do we make sure that commitment to pain management is maintained? And so that was a really excited process for us to undergo, and I think really important to how we manage pain across the system, that we learned a lot of really great lessons. And so, oops, did that show? Okay, so this was just an updated driver diagram from one of those other papers that then had just initial aim statement for one of our process. Actually, this was our process here. And there's ways, this is this was our initial driver diagram, and there's lots of opportunities for improvement in this driver diagram. It's one of our local ones here that we had initially used early on in the process. And so in addition to meeting Samina's OCD tendencies that the font sizes are different, there's other opportunities to improve. So we include this in here just so we can talk about it at the end if there's time, but ways to make these goals more specific, standardize the drivers and those types of things. And then, you know, we'd be remiss if we didn't mention again the racial and ethnic disparities within prescribing. And so Dr. Ali mentioned this earlier, and we know that several studies in appendicitis and long bone fractures and trauma as well as dental pain show that we manage pain disparately by race and ethnicity. And so I just want to try to put that lens on that too and think about that in regards to your quality improvement studies and pain management. And maybe there are opportunities once you've maximized overall, really to drill down and look at, are there some subsets of populations that are getting a different take. So not to go through all the studies, but just to, you know, mention that pain and, you know, these differences have been reported, that in the study out of Goyle, out of the PCARN data, it wasn't crystal clear. So minority children did receive less analgesics, were more likely to receive any analgesics, which is great, but less likely to receive opioids. Was it appropriate? Maybe. We've really got to drill down on those outcomes. And then, but that real outcome measure that we'd want to impact was what happened with those pain score documentation. And so they were a lot less likely to achieve a no or mild pain outcome. And so looking really closely at the data, a lot of the times it is gray. And we really just have to be mindful of it and make sure we're monitoring. Similarly, in this study by Bowden, we saw that non-Hispanic white patients were more likely to receive that opioid, less likely to receive an NSAID, both in the ED and at discharge. So taking that angle to our pain management thought is really important in this day and time. So with that, I open it up to questions, and I just really, once again, thank you for bearing with us today and having a just really engaging discussion about pain management and really trying to think about how we might apply those tools to our setting, and so that we can impact not just our own practice, but that of our colleagues, and then ultimately improve care for kids. So I thank you for your time this day, and I will open it up to questions specifically about this, but then also please put in questions about anything else that's come up during this time, and I'll let Amy and Naveen put their cameras back on too to share in this discussion Q&A. So since there's, my first question is, could Dr. Punai or Ali talk about that quick we? You talked about it quickly, and I think that's a really innovative technique. I was interested in if anybody, any of the setters or the participants have integrated that, and then how you're doing that quality improvement study or improvement process, Samina.
Yeah, thank you. It's been interesting to me for a while now. So about more than a decade ago, our European colleagues came out describing this technique to collect clean catch urine from infants without using a catheter or a suprapubic aspiration, both of which we know are at the very least uncomfortable, if not painful, depending on how they're done, the experience of the person doing it, the anatomy of the patient, etc. Right? So at our center, we know about this technique. We've had the odd doc who is European trained or European connected who's like, hey, we should use this, but it hasn't been integrated into our routine care. At the same time, our nursing colleagues who usually do it have become really, really aware and sort of acutely aware of how unfortunate it is that we have to do this procedure so frequently for febrile infants who are almost always in diapers. So we're just starting it. We're starting a quality improvement project. We're just working with our newly formed team to lead this particular aspect of quality improvement projects to look at what the best ways to reach people are. We want our docs on board, but
let's be honest, they're not the ones doing it. So our nursing buy-in, our nursing understanding is far more important. So we're engaging nursing champions. We've got a couple of physician and quality improvement process and a quality improvement process expert, and then some clinical champions. And we're including some patient partners as well, which I encourage you all to do in both your research and your QI work, because their stories and their perspectives are more compelling than anything we can possibly provide in terms of research or data. And our goal will be we'll set a number, we haven't looked at it realistically yet, but maybe 20%, that we decrease catheterization use by 10 or 20% in the next, in the 6 months from when we implement. And it'll be a bunch of things like you described, Corey. We'll do some one-on-one educational sessions, some video sharing, because the people who've created the techniques have created little videos. And then what we found worked best is when our child life specialists, when we were trying to do this for comfort positioning, when they showed nurses one-on-one how to do the comfort positioning and it worked, they bought it into it like nobody's business and never looked back. So we're hoping we'll have some nurse champions who can train their colleagues and one by one get our entire department on board. So we haven't done it yet, but we've got a lot of believers that it's going to work.
Yeah, I think that's a really awesome example of putting into practice everything we talked about. So thank you for sharing that. And then I had put it into the chat on the last one, but I really do love Buzzy. As you guys seen that Buzzy bee that Naveen put on there, he vibrates, and then there's the ice packs. We actually keep it in our IV start kit so the nurses can use it all the time, and then the little wings are in our freezer with our popsicles. And so we can you just grab them out and go. So there's just good access to that tool. And like I said, putting on it a little bit proximal for fingertip laceration repairs. I've had 2- and 3-year-olds just, watching Finding Nemo on the, thing while they're injected. Their digital block happens, no tears at all. And it's been so fabulous for that, as well as many other things that the distraction and the has helped with that as well.
Shout out, that was created by Amy Baxter, who's a pediatric emergency medicine physician. So one of our people.
Corey, aside from digital nerve block and IV insertions, what other ways do you use Buzzy? Because that little bee has just been approved by Health Canada as a medical device in the last year. So he's on our radar now.
I do like to use them for ear foreign bodies and things, just to distract, because sometimes they get just distracted with the tools and things. And so using him kind of somewhere else, just so that they feel the vibration and they're not so startled by the tool. So I'm always trying to think about ways, and just a big believer in that, after having had some dental work and having them wiggle my cheek and not even feeling the injection, the basic, those movement principles and vibration are real. And so I'm always interested in ways to think about it. Maybe that's our next children's book, guys, is thinking there's all those fun what to pull out of ears and things. Maybe we'll have to think about ways. And we have no disclosures for Buzzy or Jet lidocaine or any of those things we've talked about, just to be clear. Other things you've used. I know we didn't touch on blocks. Blocks are fantastic too. And I know Dr. Berger is a big believer in blocks for reductions and things too. But we didn't touch about, there's lots of really great other adjuncts. We were only able to cover so much. We could talk about these things for weeks. But type any other questions you've been thinking about in the chat. Ooh, that's a really good one. Naveen, talk about vapocoolant.
Yeah, we have it in our ED. Actually, one of our nurses brought it to the ED, and it has mixed reviews. So some people, in some kids, they really, really like it, and other kids, they say it hurts. So,
yeah, I think that's a great principle for anything we do, that all of these adjuncts might get the opposite effect. Like even with, like you said, the narcotics, sometimes you get the response that they feel like they're out of their body, or they feel like they're on meds, and some are more sensitive. And same thing for this too. They just hate the way it feels and cools, and some really like it.
Something Dr. Henry from PEMRAP, our dual board certified neurologist, emerge doc extraordinaire, taught me about in my early years was contralateral stimulation. So it works for adults as well as children, and in this current era where, congratulations USA, FDA has now approved your COVID vaccine for youth. So as they're all heading in now, if they're getting vaccinated here and you can't get in that space because the practitioner giving the vaccine is busy in that space, on the other side. So you could put your buzzy on the other equivalent side, or he just advocated for, and I'll do it on myself, just flicking. He's like, it's really annoying. And he had a wonderful way of describing it. He would just say, our brains are pretty simple, actually. And if one side is having a procedure and the other is being annoyed, the brain gets confused and doesn't know what to pay attention to. So it'll be distracted by the flicking. Start thinking about that, the vaccine gets done. So it's something really simple to do with someone who is, but you have to gauge your person. I'm not sure every 5 or 6 year old would be okay with an adult flicking them. Teenagers probably more okay with it if you explain to them what you're doing right after. So choose your audience, but just the idea of contralateral stimulation with the buzzy or even just with your fingernail is a really cool idea for ways that we can modulate how the pain is experienced by the brain. And of course, this distraction. It doesn't affect pain directly, but it affects our perception of the experience and the pain. And then for children, especially how we talk about it after. So even if it was really upsetting for them, even if they cried a lot, even if they were super upset, as a parent or caregiver or healthcare provider, how we frame it is really important, because that's what they're going to remember. So as they walk out, so yeah, doctor told me I was really brave, right? Or the doctor said they really liked how I blah, 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 how I held real still, even though I was screaming down the house. Whatever positive thing they did, focus on that. Or a poke prize is another way. We give tiny little prizes so that when they walk out and they're asked a week later, how was your emergency experience? They don't say, I got a needle. They say, I got a silly sticky dude that is now stuck to my parents' ceiling and will never come down. But that's what they remember.
Yeah, and I think that was really important, Samina, and I don't think we definitely talked too much about it, but the language we use and the ways we teach kids to cope, I've learned exponentially from our child life specialists, and we have our child life tips and language of the day are posted routinely in our core and the restrooms in the ED, and they're another great high visibility site that, are opportunities for education and thinking about the language we use and hold still and don't cry or I'll have to do this again, and those types of things, aren't super helpful. Joelle, did you have a comment?
Well, kind of a question, and it's very much coming from my perspective as an incoming trainee. I've noticed in pediatric EDs that a lot of times children are taking cues off their parents, and if you have a parent who's anxious about any procedure, it doesn't really matter what you do, the child's going to be anxious. So I guess what tips and tricks do you have for getting the parents in the right mindset, especially if it's someone who is, especially if you have a parent who's afraid about this, because that's who I notice children tend to look to first, regardless of what you're doing with them. So if anyone wants to jump in on that, it wasn't to anyone specifically.
That's a fantastic question. I'm just trying to not talk, which is really hard for me.
I can start, Joel. Thank you for that question. I think parents are almost always our allies in these situations, and universally 100% of the time we should ask them, parents and caregivers, because they're not always parents that come in with the children, but if they are positively interacting with the child, they are our allies. We should 100% ask them if they want to work with us to help make the experience better for their child, but also have zero judgment if they're not in the space to do it. So every so often, every 100th or 200th patient, I'll have a parent who'll say, I have an anxiety disorder or I have a needle phobia. I can't deal with this. No problem, sir or ma'am. or, you know, whomever, you are more than welcome to leave. And we'll, you know, this is how we'll work it. Why don't you stay till they fall asleep, and then they won't know that you're leaving for the reduction of the fracture, that kind of thing, right? But if we can help empower, and generally, if you empower a parent to be part of the treating team, their anxiety and distress level goes down. A lot of our anxiety and distress as caregivers comes from feeling helpless. So when you give them helpless, and your child is in trouble, right? And so if you give me a task to do as a parent, suddenly I become a lot less distressed. So we can integrate them. Obviously, you're not going to hand them the needle driver, but they can, of course, reassure their child, hold their child's hand, use positive words, give sucrose to their infant, breastfeed if that's in the child's repository of things they do, all kinds of things they can do.
Thank you. I appreciate it.
Yeah, and working out a lot of the times, especially now in COVID, where there's only a dynamic, sometimes you would have the other 8 children in the room and grandmother and you know, the neighbor down the street. But now at least usually it's a duo, at least our restrictions we still have in place. And so, but thinking about what is best for the child and for the parent too. And sometimes then I end up giving my whole sunscreen after the laceration and having like doing their whole talk to just distract the parent, and that they're the big focus. The kid's fine as long as you get the parent to stop messing with them. And so it is definitely a skill. And I really abhor you to utilize your time. And, you know, you may have had widely various experiences with laceration repairs, or once you're a fellow and it gets crazy and you're just doing them on your own. Take those opportunities to learn from the people that do it best. Because I learned so much from like lurking outside the door and hearing how people interact with the patients. We've got an attending who's a master of starting to sing the alphabet on B. I don't know if you've tried that before. I'm not going to do it for you. You know, to really just try to, and then because the kid usually can't do it, but you can try to make the parent do it and get them distracted doing other things. So our distraction and those kind of techniques you can do on the parents as well.
Awesome. Thank you so much. I appreciate it.
I'm just going to put up our last takeaways. There's so many great ones in here interspersed throughout the talk. I believe the online content, Susanna maybe can help us with how long it'll be up or available through SAEM, but this talk has been recorded, and we want you to share the messages and lessons learned for sure. So we hope that we've spent the last little bit of our day convincing you that child's pain matters, and that we really, in order to manage that pain, we've got to assess it, and we got to reassess it, and that the child's the best report of their pain, but if they can't, using the parent as the surrogate, and that everybody should get those 3 Ps, that physical, the psychological, and pharmacologic management, and not thinking that you chose one, so let's just give that opioid. Let's not think about that multimodal therapy, and then giving them that education about it, that they can use those various medications on discharge as well. And how do we think about how we give the discharge education? How might we better be able to standardize that, or provide them the websites for some of these really cool resources? And that we really do feel like opioids should be used judiciously but responsibly. So treat the pain first, and then ask the questions about the opioid use. The script Dr. Ali provided is fantastic and available on those websites. And so thinking about how you talk about it. And then pain management doesn't end in that ED. You really want to keep them comfortable and learn the tools in the toolkit to be able to use those strategies and then use those other adjuncts as well to manage their pain in the future. And that really there's quality improvement opportunities everywhere. A lot of them are not hard. They don't have to be QI, like we said, is a rigorous science, but they don't have to, not every improvement needs, metrics. And if you want to make a patient care improvement immediately, there's opportunities to do that as well. We invite you to study them rigorously and contribute to the literature, and so that folks can learn from your projects, but we don't just want you to stop there. We really want you to follow your heart. And I'll invite each of our speakers to give one last closing thought too, which I didn't tell them about in advance, so sorry about that.
And our content should be available, I believe, through the end of October.
Fantastic. Thank you.
Yeah, I appreciate everybody's attention today and participation. It's been really an engaging discussion. I know I've learned a lot, so I appreciate everybody's input as well. Yeah, so thank you very much for all that you guys have done to make this such a great session.
I echo Amy's comments. I definitely learned a lot with you guys. You're a very engaging group, and I had a lot of fun doing this. And you know, hopefully we can do it again next year, and we'll have some more tools in our tool belt as to how we could better manage kids' pain.
And I would echo all of those and just end with my favorite quote from the Dalai Lama, which is, "Pain is inevitable, but suffering is optional."
Fantastic. And then am I still sharing my screen, DLC? Yay. Okay, cool. How do I do next? That was us. I do send you to a resource that's 10 practical ways to make your ED less painful and more friendly, as well as all those resources throughout in the studies, especially because this is evidence-based. There's great data behind this, and we really just want you to go forth and improve pain. And then we look forward to collaborating you with it in the future. So thank you for the time today. Get involved in the talks at SAEM. And keep doing that good work. And we really do thank our two medical student ambassadors, Joelle and Danny, as well as Dr. Berger, who is helping us facilitate today. And we hope to see you again in the future. So thank you much.
Thank you, everyone.